Good morning. Good morning. Thank you so much for joining us this morning. Welcome everyone to the pros, the cons, and the buzz about single-payer health insurance system. My name is Deb Knight, and I am here today representing both of our sponsoring organizations, the Missoula chapter of the American Academy of Professional Coders. The AAPC mission statement is to advance the business of healthcare by providing professional training, industry standard certifications, and comprehensive solutions to individuals and organizations across medical coding, billing, auditing, compliance, and practice management. Founded in 1988, we are 175,000 strong and continue to grow and expand. By a show of hands, how many AAPC and AHIMA members are in the audience? Wow, right on. So please make sure that you've registered with Carrie in the back. Carrie, raise your hand. And she will have your certificates when the event is over. The Missoula chapter is pleased to offer these CEUs to you at no charge. The League of Women Voters. The League of Women Voters is a membership organization open to any resident, male or female, 16 years of age or older, interested in supporting the basic principles of democracy. The League was founded nearly 100 years ago. We are best known as the nonpartisan organization responsible for registering voters and moderating candidate debates. In this spirit, these two organizations come together to discuss an issue both are passionately committed to. Along those lines, during this event, we won't be debating public policy, solving world problems, or discussing details of personal medical issues. If you work in the medical field, you know it's amazing what people will tell you. This venue is to offer you information to help you ask more informed questions in order that you may make well-informed decisions. More information about the League is available at the table at the back of the room. Representatives will be there after the meeting and to answer your questions. For non-AAPC AHIMA members, please register with the League representative. I want to take a moment to thank the Missoula Community Access Television, MCAT, who is here today recording the presentation for future rebroadcast on the Missoula local community cable TV station. This presentation is being recorded by Missoula Community Access Television as part of a media assistance grant donated to the League by MCAT. The franchise for cable television, which is critical for MCAT's continued presence in Missoula, is up for renewal this year. Please go to the MCAT website in April and fill out the Community Needs Survey and sign up now for one of the public meetings. This happens once every 10 years. The public needs to be active in demanding MCAT services to give the city bargaining power in the franchise negotiations. You may be wondering why the League of Women Voters is co-sponsoring this event. The League believes that an informed citizenry is essential to the quality of our democracy and therefore supports forums geared to providing information and discussions on the issues we face. Now a few words about logistics. Please silence your cell phones. Restrooms are located down the main hall as you exit left and right. The program will continue uninterrupted until 1 p.m. Feel free to come and go as you need, being mindful of your fellow audience members. Refreshments. There's water, coffee, tea, and light snacks available. Feel free to get up and help yourself. Again, being mindful of your fellow audience members. Questions. We will be handling questions the way we do at most League events. If you have a question, write it legibly, and I say that legibly because I have really crummy handwriting, on one of the index cards you received with your program. If you don't have the program, the handout and index cards, please let the gals in the back know. League members are available to bring you additional cards if you need. Hold up your card and a League member will pick it up and integrate it into the questions that will be posed to the panel. This ensures that everyone can hear the questions, including the panel members and MCAT. The film we'll be watching today is Fix It, Healthcare at the Tipping Point. The film was 2 years in the making with more than 40 voices advocating for reform, including activists, health policy experts, economists, physicians, nurses, patients, business, and labor leaders. This documentary takes an in-depth look into how our dysfunctional healthcare system is damaging our economy, suffocating our businesses, discouraging physicians, and negatively impacting the nation's health, while remaining unaffordable for a third of our citizens. It is produced by the Unfinished Business Foundation from Easton, Pennsylvania. We are fortunate to have with us today 3 panel participants who will present their views of single-payer health insurance. Then we'll begin the Q&A session. Dr. Bryce Ward is the director of the University of Montana Bureau of Business and Economic Research, the Healthcare Research Program. Dr. Ward, please raise your hand. Okay. Dr. Carter Beck is a neurosurgeon at Providence St. Patrick Hospital. He's a past president of the Montana Medical Association and currently the Montana representative to the American Medical Association. If you know Dr. Beck, you know he's very passionate about single payer. Dr. Mark Mantell is the Associate Program Director for Osteopathic Curriculum, Family Medicine Residency of Western Montana. Dr. Beck and Dr. Mantell. The panel will be moderated by Lisa Ray Roper. She is a certified AAP instructor, a fellow of the American Health Information Management Association. Wonderful lady and my mentor. I'm going to turn it over to Lisa Ray. Thank you for coming.
Good morning, everyone. Wonderful to be here. Thank you, Debbie, for inviting me, and thank you to the League for inviting me as well. As Debbie mentioned, we are going to have a Q&A session, and so we really hope for robust participation during that. When your questions are answered, we will be reading them here from the microphone, so everyone has benefit of that, and then we will be addressing them to each of our panel members to be answered. When you did come in this morning and you registered at the back of the room, you were given 2 index cards. Now, we certainly are not saying that you can only ask 2 questions. You could ask more than that. So if you'd like some more, just raise your hand and we will circulate and get those. I'd like to bring your attention to the handouts that you did receive when you came in this morning. One of them looks like this, and I know from the benefit of the back of the room, it's difficult to probably see what I'm holding up. But this has the AAPC and the League of Women Voters at the bottom of it, and there is an agenda that's listed on there. You will notice, as Debbie said, that there is a break being listed there, but again, this is going to be an open forum, so you can come and go as you please. And the courtesy of those around us, just make sure that when you do come back in, certainly grab some water, grab whatever you'd like to do, and rejoin us. The next thing I'd like to draw your attention to is the second handout that was also available to you. That second handout is a multiple-page handout, both front and back, and it has a glossary of healthcare coverage terms. As we all know, here in the United States of America, we are underneath a multi-payer system. And being underneath a multi-payer system, what does that really mean? It means that we have a lot of different interaction for payment to be coming in to different healthcare coverage systems. So we have both people who are paying privately out of their pocket. We have people who participate possibly in commercial insurance plans. We also have people who participate in federal and state funded and private funded plans as well, such as Medicare and Medicaid. We also have people who are participating in plans like the Indian Health Service systems or the VA clinic systems, or even in workers' compensation. Now, what does that mean to us? What it really means is that each of those different organizations has an opportunity to make their own rules, policies, and regulations. Even though there are some very basic tenets and underpinnings of all of the healthcare plans that say that they have to follow certain types of rules, they still have an opportunity to say, well, in our plan, we participate and we offer insurance to our participants who have purchased that insurance, but in order to pay for that insurance and pay for a claim, there are these 90 pages of rules and regulations. Now, when we go to another plan, there might be 92 pages of rules and regulations. So from a payment system and from an administrative system, it makes it really difficult to deal with all of those different plans. As Deb said, we're not here to debate what's right and wrong about the healthcare systems. We're here to really talk about what does it look like today. We're here to learn about what one-payer systems could look like. And during that learning event that we're going to be participating today, the reason that we gave you these terms and terminology is you might be hearing some of these in the movie, the documentary that we're going to see, as well as from our speakers. Many of the terms that are listed on this handout are going to be very familiar to many of you, but we put it in your packet just as another learning device in case you say, gosh, later I'd like to go home and read this because I would like to go to sleep immediately. If so, I'm going to turn your attention to page 4 because that's really a nice page to look at. Page 4 is a nice little document that moves from left to right as we read across there. It just is an idea and an example about how your health insurance shares costs. So again, it's just a nice little diagram that moves across to say this is possibly how a health plan could work. During today, if you have questions that you would like to have addressed as they're written on the cards, if you would like them to be addressed to one particular panel member, I'd ask you to write that at the top so that I know who to address it to. If there is not a panel member's name at the top of the card, then I will address it to the entire panel and ask for input from each member. If you do have other questions, certainly put those on the cards and we will answer those as we can. And again, we will have the League of Women Voters coming around as members and picking those up. So when you have a card ready, it's sort of like when you go to a bidding auction or a bidding war and you just start holding up cards. So if there's anything really great to bid on, especially if it's something to eat and or drink, my card's gonna go in the air a whole bunch of times. Okay, so we'd hope to see those cards. We're gonna go ahead and start the movie, and as Deb said, feel free to get a drink or to use the restrooms if need be. We would ask that if you are taking a phone call because your phones are on silence, so we would ask if you're going to do that, that you would please leave the room and then maybe walk down the hallway just a little bit away from the doors so that you could have the privacy of that conversation. When we do come back together in just a few minutes, when we do come back together after the film, then all of our panelists will be here at the front. And our panelists and Debbie and myself are going to get up and move so that we have the benefit of watching the film with you. Again, thank you for being here.
Over this period of 35 years, the company grew from 0 to 170 million in sales and became the leading company in both the picture frame industry and mirrors. From 1980 into the 90s, we were doubling our size every 2.5 to 3 years. As a result of foreign competition, our gross profit margins deteriorated. We had to watch every penny of overhead. We've gone to our customers with a price increase, they've rejected, all right? So we've got to figure out, in order for us to maintain profitability and margins, we've got to figure out how to do things more efficiently. So here we are, we're mobilizing our resources very carefully. We're controlling costs. And the one area that was so confounding was healthcare costs. We saw the passage of the Affordable Care Act. But the cost to our company and our workers continued to rise dramatically. We would be faced with double-digit, sometimes high double-digit increases.
The premiums in total for healthcare costs has actually doubled over the last 10 years. That's an exorbitant increase. That's more than any other expense has increased over that same 10-year period.
Pity the company that's more labor-intensive than us. They are going to suffer dramatically. And if they are having bad years, if they're on the verge of collapse, this is going to push them over.
Picture frames aren't an expensive product. So even a few cents on picture frames makes a big difference in how we sell that product. So we're looking at every penny, every half penny on this product. It makes a big difference in how we can sell this product and how profitable we are.
After years and years of incurring these significant cost increases, I started to look into healthcare. The one great thing about MCS is if there is a problem, we deal with it straight ahead. We investigate, we resolve, we fix.
A worker making minimum wage could work full-time for an entire year, not earn enough to pay for a health care benefit.
For an average family of four, this year's number is $23,000. That's what a typical American family insured that way costs.
And they have this false sense of security that they're in a plan that provides them protection. But regrettably, all too often, people find out when it's too late, after they've been sick and been hospitalized or injured and requiring expensive treatment, that their coverage was not nearly what they thought it was.
The shock only comes when you have to use your insurance. You feel like you have health care insurance and that entitles you to health care, but it doesn't.
You might as well say it's not really an insurance plan. That's how outrageously priced our health care plans are today and how unaffordable they are.
And insurance companies are able to charge older people 3 times as much as younger people for the exact same policy.
Their potential employer sees them as a risk. The age 50 to 64 age bracket includes very high rates of uninsurance within the U.S. market, and it's because these are very expensive employees.
It makes it less likely that employers will even consider hiring someone in their 50s, for example, or early 60s.
There's all kinds of costs and unintended consequences that come with having your health care depend on your job. It may be that you want to move to a different job, or it may be that you got laid off because of a recession or a downturn in the business.
I've talked to people who've told me they've not gotten a raise in 5 years because the money they would otherwise have gotten in raises has gone to insurance companies.
We've created a very fragmented system in which coverage is tied to employment in ways it isn't in most other countries in the world.
If you and your family lose their whole health insurance because of a change in your employment status, that's an incredible insecurity, an incredible burden for families to have to bear.
So the whole idea of having insurance that protects us from financial ruin, it just doesn't exist anymore for most people.
And this is why of 1 million bankruptcies in the United States, over 60% are associated with medical conditions. And the great majority of those are people who have health insurance.
We went through years of working hard only to lose everything. Lose our home, go bankrupt. What a shameful thing to do to people.
You see these numbers of people who don't have insurance and families who are driven to bankruptcy.
If you talk to most families, they can identify at least one person in their family who's really struggled with healthcare issues and how to finance those issues.
40,000 unnecessary deaths every year because there's no health insurance. And these are real people who are suffering and who are dying.
Of course, I had health insurance, but I never actually thought a whole lot about it. I paid the premiums. I wasn't using anything that much. My out-of-pocket expenses were pretty much nil. But then Bill got sick, and he was hospitalized. So all of a sudden, these bills started rolling in, and my insurance wasn't covering everything.
In 2014, a family that was paying $4,000 to $5,000 as a premium share, and MCS was paying $13,000 to $14,000 as their share of the coverage, that family could pay another $6,000 or $12,000 if 1 or 2 people got sick.
It's really devastating to a lot of people when they can't afford health care and when it's impacting their family life. And you're already afraid because there's a family member who is sick and now your expenses have increased while your income has decreased.
We're up around $10,000 in expenses. What would happen if I would get sick? Our expenses would be probably up around $16,000 a year. That's unbelievable. If anything happens to me, we're done.
Let's look at an employee who makes between $18 and $19 an hour, makes $1,500 every 2 weeks, has a take-home pay of $935. That employee, if someone gets seriously ill in the family, will essentially be wiped out.
All those years that I worked and that Bill has worked, it's going to be for nothing. We're going to lose everything that we have. All you feel is hopelessness. You don't feel like there's any way that you can get out of this, that you're stuck. This isn't fair. This should not be happening in the United States.
The thought that my employees, members of my work family, are susceptible to this challenge from medical costs is not acceptable to me. It should not be acceptable to any employer in the United States.
My father, late in his life, was an over-the-road truck driver. He had some modest success and kind of went from one truck that he drove himself, buying a second and third truck, and ultimately having a couple of employees that drove for him. He had achieved in some very modest and small way, late in his life, the success that I think he always had dreamed of. Unfortunately, he suffered a kind of catastrophic truck accident where his truck actually flipped over a guardrail and landed on the highway beneath him. I will never forget being there when he woke up in the ICU, and his immediate reaction was to try to rip the lines out of him and get out of there. And I said, you know, Dad, it's okay, you're in the hospital and you're in the ICU, it's gonna be all right. And he said to me, you know, you don't understand. He said, I can't afford this. I gotta get out of here. And it bankrupted his company. So the two folks he had working for him didn't have a job anymore. Doing all the right things, playing by the rules, working hard was all eliminated like that with one accident. And I never forget kind of what it did to him. It kind of broke his spirit, quite honestly. And he was never really the same man after that.
Every employer I know, and I'm talking about small to medium guys mostly, they dread the next hike in their insurance rates. So we've got people who fear they're going to be put out of business if they have one employee or one spouse or one child that has some kind of a huge healthcare event.
Hemophilia is one of the most expensive diseases to have. Right now, my medication is upward to around $50,000 a month. There is no cure for hemophilia, so at least $50,000 a month for the rest of my life. Shouldn't happen where you're hired for a job and then to find out that they're going broke because they're trying to afford health care for me.
The current costs of the system are becoming intolerable. And as they become intolerable, their business naturally is going to look for other solutions.
It distracts businesses from doing their primary function, precludes them being able to budget for hiring, for investment, for expanding their enterprise.
Why are we creating an extra hurdle for business? It's tough enough out there. You know, why are we making it harder for people to provide goods and services to the American public while employing people and providing tax revenues?
I often ask folks that I work with who own businesses, tell me one thing in your business that you spend, the kind of money you spend on health insurance that adds no value to your business. There's a middleman, an insurance company that isn't improving your employees' health, that isn't saving you money, and that is not doing what's best in the best interest of our economy.
Healthcare costs are going up 2 to 2.5% above the projected growth of gross domestic product. So it is running away from us. Healthcare costs have gone up to $3 trillion We've gone from 7% of the economy back in 1971 being healthcare to 18% today.
When the rest of the world is spending less than 10% of their economies and getting health care to all of their citizens.
There's been a reduction in consumer purchasing power that can be directly associated to the increase in medical costs in the country. If you now have a $1,000, $2,000 deductible, that is money that is not available for you to get a new car.
More disposable income to spend translates into more demand for the goods and services that employers are in business to produce and sell.
In the city of Philadelphia, where school teachers are being laid off by the thousands, and where classroom sizes are escalating above 40 students per teacher, and you don't have proper security in schools. Children are being taught on the 4th and 5th floors of buildings that don't have air conditioning or proper heating. We are undermining our capacity to function, let alone compete as a society, because of the rising costs of healthcare.
People don't realize that huge federal deficit that we have in this country is related to the fact that we have this enormous healthcare cost bill.
Part of the indirect cost of healthcare that most people are not aware of is that their taxes will continue to go up to pay for this broken healthcare system.
We're here at the Bethlehem Wastewater Treatment Plant here in Bethlehem, Pennsylvania. And this piece of equipment behind me is a 40-year-old piece of equipment that's been basically taken out of service. We've got a rental unit that we now pay $17,000 a month to lease that piece of equipment. So that $17,000 of additional cost monthly expense is going to get passed on to the sewer customers in the form of rate increases. And this plant in general is just one small example of what the true impacts are of the spiraling costs of healthcare and our inability, whether it be here in the city or as a country, to address the infrastructure needs that we have throughout this country. And essentially what we had to do is starve other departments and other areas of the city in order to continue to accommodate those increases in healthcare costs.
If an ICU stay costs $30,000 a day, we're shelling out as an employer, when by virtue of being self-insured, $30,000 a day. That's half a police office for a year. Depending on the amount of long-term or significant illnesses you have in any given year, can mean swings of millions of dollars on an annual basis. An average tax bill in the city of Bethlehem might be $2,500. If you figure that for every dollar is 33 cents on the dollar, it's about a $750 bill every year that the taxpayers of the city of Bethlehem are paying to provide health care for our employees. How are we going to make the ends meet, provide the city services that our residents deserve, and do it without having to raise taxes? Senior citizens are struggling to stay in their home as it is, and you can literally tax people out of the home that they've had all their lives.
I remember 35 years ago when healthcare was affordable. MCS had great insurance, full coverage with minimal deductibles. U.S. employers across the country provided well for their employees. No worries. That's all been eroded by a relentless increase in healthcare costs. Today, there's a dark cloud of anxiety in the country, a dark cloud over our employees. They're one diagnosis, one accident away from financial disaster. A few sick employees can take down a company. The dark cloud hangs over our cities. No money for infrastructure, no money for schools, high taxes. That dark cloud hangs over our whole economy, causing flat wages and no money to spend to fuel real growth. It's a problem that we have to solve. In 1969, Blue Cross Blue Shield had community rating. Everybody paid the same rates. It was a truly nonprofit, and in every state, Blue Cross Blue Shields were regulated to serve the public interest. That's what we gave up on.
So executives at life insurance companies saw an opportunity to come in to this area, come into this space, and make some money. So they came in and started offering cut rate policies, but only to those who were younger and healthier. The group of people subscribing to Blue Cross Blue Shield became less and less healthy, more and more expensive, forcing the Blues to raise their rates more and more. And by the late 70s, early 80s, in every state in the Union, the old Blue Cross Blue Shield model was dying. These companies were going bankrupt. Non-profit companies couldn't make it. For-profit insurance companies over the years became so dominant that they actually came to control the healthcare system. They bought a lot of the Blue Cross plans. A lot of the Blue Cross plans now are for-profit companies.
The U.S. has one of the shortest lengths of stays in hospitals of any country, and we're told we have to shorten it. We go to the doctor about 4.2 times a year. The Japanese go 13 times. So we're told that we use too much health care and we have to restrict access to save money, when in fact we're below average when it comes to comparable countries.
The whole system is set up to discourage people from using health care.
The insurance companies are specialists at figuring out ways of covering less or paying less the sicker you are.
So not only are people having to pay more money out of their own pockets for care in these plans, they're finding that the choice of providers has been narrow.
As a primary care physician, I have selected the specialists that I'm most comfortable working with. As it stands right now, I've got to say to my staff, check if Dr. Brown is a member of this patient's insurance. And so referrals are so much more limited in the current system.
People have precious little choice today. Frequently, people will look at their plan and realize that their doctor is not on any of their plans.
The choice we need is not choice between insurance companies. As a matter of fact, we don't choose our insurance companies in general. It's your employer, if you're getting your insurance through an employer, that chooses the insurance company. And that's really not based on the quality of the insurance most of the time. Most of the time it's based on the cost of the employer.
One of the reasons I left the industry was because I was expected to be a cheerleader for consumer-driven plans, or plans which have high deductibles, and to persuade the American public, employers in particular, that everyone needed to have more skin in the game. What the companies were doing to meet Wall Street's financial expectations was to make it less likely that people could get care that they needed, that they could afford insurance. And that's when I decided I had to find some other way to earn a living. I was being paid, in my view, to mislead people, and I couldn't in good conscience keep doing that.
Medicare. And they talk about that it's broken, that it's unaffordable, that the costs are escalating. And this is an enormous distortion of the reality of Medicare. In fact, Medicare has been a runaway success.
Well, Medicare can take care of the sickest and the oldest in our society, and they can do it actually at far less cost than the private insurance companies could do.
They don't have the same kind of cost that the private insurance companies have. They don't spend enormous amounts of money on their sales and marketing teams and on advertising. And they don't need to have an infrastructure in which they're going back and forth with healthcare providers on a daily basis to try to determine whether or not something is a covered benefit, which is also something that eats up an enormous amount of that premium revenue.
I was the administrator of the Centers for Medicare and Medicaid Services, that runs both of those programs, and the Children's Health Insurance Program. We had 5,500 employees in that system to cover the whole country. Our budget, the amount of money going out to the healthcare system, was about $820 billion a year, nearly $1 trillion. Total overhead budget, that is the administrative budget that I had, was about $8 billion, 1% of the total. That probably undercounts, so let's make it 3%, 4% of the total budget. Right now, by policy in this country, under the Affordable Care Act, we are trying to argue insurance companies down to 15% overhead.
The American taxpayers are saddled with the poorest in our society and the oldest, and those with chronic disabilities and those on dialysis. And we're putting them in the government programs and saying, all you healthy people from 18 to 64, we're going to hand it over to private insurance companies. And still, even with doing that, Medicare manages to actually control healthcare costs better than the private insurance companies can.
If you suffer from end-stage renal disease in the United States, irrespective of your age, you are covered by Medicare. And if you are blind, you also are covered by Medicare, even if your child was blind. So we've established the precedent already in this country of having one payer pay for all the care needed for 2 organs by just adding the heart and the liver. That would have gotten us a long way towards universal coverage.
Medicare isn't the problem. It's a wonderful example of the kind of solution that actually works and is consistent with the international standards in healthcare.
It's the system as a whole that creates the inefficiency. The fact that there are so many different payers and so many different plans and so many different ways in which bills have to be made and collected.
So having multiple insurances and having multiple ways of even billing for that patient is adding to the inefficiencies of the patients. You look at quality and variability, they're opposite of one another. The more variability that you have, the more entities, provider, payer, insurance manufacturers, and so on, the more chances of error, the more inefficiencies, the more cost.
One of the reasons why hospital bills are so high, why we are charged so much by doctors, is because they have to spend a lot of resources. They have to hire staff who do nothing more than engage in a nitpicking war with insurance companies on a daily basis to make sure that they are getting paid appropriately.
It makes me angry to see so much waste in healthcare, that there are nurses who are pulled away from actually providing hands-on patient care, and they're pulled into administrative duties. And they're pulled into those duties because we have an incredibly complex billing system. We have many different payers in our billing system. We have people who can't pay, people who have this insurance, people who have that insurance. So there's nurses whose full-time job is to help get authorization so that a patient can get the care they need. And that's ridiculous. I would really love to be a nurse without having to think about whether or not a patient can get the care they need, whether or not a patient is sent home from the hospital without the proper medications because they can't afford it, whether or not a patient is going to be able to get a treatment that a doctor recommends because their insurance company won't pay for it and they can't afford it. I'll go into a patient room on a day of discharge and I'll find a patient who tells me they're not ready yet to go home. They say, I'm fearful, I still have pain. The doctors and the nurses share these frustrations that an insurance company would make a decision to send a patient home too soon. I have seen parents make decisions that would put them into bankruptcy to get their children care. They love their children and they want to do everything possible. They didn't understand their actual health insurance. Health insurance is a really complex system. Families will sit in rooms and cry over whether or not they're going to be able to face this, whether or not they're going to be able to afford it, whether or not they're going to be able to keep their job, whether or not they're going to keep their insurance, what's going to happen to their house, etc. Nurses see this on a day-to-day basis, and it does break your heart.
We as a small practice of 5 doctors and 1 provider deal with about 20 different insurance companies at this point. We have a middle office that has 3 people in it and an office manager that deal with essentially insurance issues and payment issues all the time. If I write a prescription and they want more information, my nurse has to call up that company, wait for their telephone system to come up with a live voice, give them the particulars of the patient and the medication, but it's not uncommon that they spend 30 minutes with 1 appeal. So we're trying to figure out the game so that we spend the least amount of time doing that kind of baloney. Every physician spends $84,000 a year just to interact with the private health insurance industry.
To care for my patient in a proper fashion, in a day-to-day basis, I need at least 2 people to take care of all these denials. I have a patient who specifically, for example, needs an epidural. because they have a herniation of disc. They have a proven MRI, they have physical exam, they have all the documentation. I still get denied.
Doctor wanted an MRI ordered. Patient was in excruciating pain, unable to walk. We attempted the MRI and we were told no. Patient had to have 6 weeks of physical therapy. He endured 6 weeks of physical therapy. His symptoms got worse, but in the meantime, he had 5 office visits, 2 ER visits, an admission, a transfer to another hospital, and finally a rehab hospital. And it just blew my mind that we could not get the MRI approved without 6 weeks of therapy when we had a person that could not walk. We deal with insurance companies all day long, and we document every conversation we have, who we spoke with, when we spoke with them, because depending on who you get on the phone, you'll get a different answer every time you call in. If we did not have the staff that we did, we would not be questioning half of the claims that we do. It's very time consuming and it's extremely frustrating.
So insurance companies increasingly are the force in the room, unseen but powerful. When you're in the hospital room, that's who's really driving a lot of the decisions that you make. How long you're going to be in the hospital, what drugs you're going to be given, what access to providers or tests that you have. Those things are increasingly driven by the insurance company reimbursement.
Multiple insurance companies telling me to bill less and do less to the patient. And based on their reimbursement, giving me 10 minutes to see a complex patient. That is not possible. So we concluded the only way we could continue to do what I was trained to do, what I thought was the right thing to do, was to get rid of these insurance companies. We made a decision to move to a single payer. We started taking Medicare and Medicaid and other government insurances. That's how we moved to a single payer. We had to give up almost 70% of our practice, which were commercial insurance. I certainly have a lot less patients than I had before.
MCS pays $1.5 million a year for its health insurance. And where does it go? 3 cents of every dollar goes to an insurance agent that represents MCS in selecting an insurance plan and negotiating price. The next 20 cents of our premium dollar goes to the insurance company for its sales and marketing expense and for its staff, the pre-approve and deny care, and its administrative expense. And then you have at the provider level 10 to 15 cents that goes to hospitals and doctors to interface with my insurance company. They face massive amounts of paperwork and phone time dealing with pre-approvals and denials and payment issues. None of it is related to care. That's 33 cents of our dollar before the actual cost of care is paid for. My insurance company is supposed to negotiate better prices from the providers, but on average, they end up paying 20% more than Medicare does. They pass that extra cost on to my company. I don't see what private insurance brings to the table.
What keeps insurance company CEOs up at night is the worry that other CEOs that will eventually come to realize that they add more cost than value to our healthcare system. And that more and more employers, corporate executives are beginning to understand that. Since I have been known as an outspoken critic of the industry and an advocate for change, I've gotten calls from a lot of people I used to work with who said, thank you for doing what you're doing. You are telling the truth.
I cannot read my insurance policy. I don't understand it. I can't figure it out. With all due respect, if I can't figure it out, most people probably can't. That is waste added. It's not transparency, it's confusion. When you have a publicly accountable system, as we could have a single payer, you can have less confusion.
Over and over again, we're hearing the same plea. The system is too confusing. We need to have simplification to control costs and to improve quality. And what about single payer health insurance? What does it mean? One entity that pays the bills. We get rid of the hundreds of complicated insurance plans, and we have one comprehensive plan that covers everybody. It's simple and efficient. You go to any doctor or any hospital you want, present a card, and you're covered. There are no deductibles, no out-of-pocket expenses, and no contentious pre-approval before treatment. Everybody is covered. Nobody is left out. Single payer is not a government takeover of healthcare. The doctors and hospitals remain totally independent, just like they are with Medicare.
If I told you that every one of your employees could get the health care they need guaranteed, then your costs would go down. Everyone would pay less and get more. You might be skeptical. But the truth is, most every country in the world does that.
The benefits in Taiwan's single-payer system are comprehensive. You have inpatient care, hospitalizations, visits to doctors, drugs, dental care, child delivery, dialysis, all of that is paid for. Patients have complete freedom of choice of providers. Taiwan spends 1.6% of its total operating budget on administration. And that is a tiny fraction of what we spend in this country. It's the peace of mind that it gives people, which Americans don't have yet. I hope every American has that someday.
One of the myths about universal healthcare systems is that they engage in rationing. That they, in order to cover everyone and operate within a budget, they have to severely limit access to specialty care and surgical care. And our research has shown that that's just not the case.
Our current broken healthcare system is the most rationed healthcare system in the world. That's why a third of Americans don't get the healthcare they need.
The idea that you can have high deductible policies and that you're not rationing healthcare by income class, I would say, where were you educated? That isn't even requiring a PhD, that's just common sense. Think of a waitress making $30,000 and you ask her to cough up $10,000 out of pocket.
One of the biggest differences between the United States and the rest of the world, studies by the Commonwealth Fund and others find Americans are much, much more likely than people in other countries to defer medical care because of cost.
We have a large number of people dying from causes that should be preventable. So when one takes all these causes of death, which one should not die from, given access to appropriate and effective medical care, the U.S. comes out as number 19 compared to France, which in fact is number 1, or Australia, which is number 2. No question in my mind that our low ranking on avoidable mortality is due to the fact that we still have financial access barriers to the most basic kinds of services in the United States of America.
The data shows very compelling information about single-payer systems. And so it was imperative that we visit a single-payer system and experience what life was like on the ground. Fortunately, we've got a single-payer system operating to our north in Canada.
This is our high-resolution CT scanner, and it's a very important part of the equipment that we use to make a prompt diagnosis for our folks with a variety of disorders, medical conditions, and trauma. And this is Dr. O'Connell, and he's currently speaking to a group of residents in a room with, as you can see, the flat screen technology.
Since around October of 2013, we've had on-site 24-hour-a-day staff radiologist coverage here. Our subspecialty staff with emergency trauma radiologists full-time. And we're the first site in the world to offer 24-hour-a-day cardiac CT scanning.
There was a short time after I moved here, and
I had a house looking out over the lake, and I just had a strange feeling. I'm trying to put my finger on it. This was a peaceful feeling, an absence of stress. I found that I was really quite unencumbered when it came to seeing the patients, that I could concentrate on doing medicine and not worry about other things. And that was quite a change from what my experience had been. I worked in community health centers in Oakland, California for many years. I was the medical director there and the medical director also of a consortium of community health centers also in the East Bay area. I left there in 2004 and moved to Canada. Sometimes when I'm driving around here, I think, oh my gosh, I'm back in a Marcus Welby episode or something. First family practice department meeting that I attended here in Canada was quite an experience. People actually seemed happy. No one was talking about the latest outrage that had occurred from some insurance company. No one was complaining that they couldn't see their patients anymore.
As a Canadian physician, I sort of laugh when I hear people talk about government, telling me what to do or government-run healthcare. That's certainly not been my experience working in the Canadian healthcare system. I have an enormous degree of clinical autonomy.
People seem to think that because there's a single payer, that you are working for the government. You're an employee. They tell you what to do. Nothing could be further from the truth. I'm in practice. I'm a small business person. They're not running my business for me. They don't come in and review me and tell me, you're not doing this right, you're not doing that right. They're the ones that pay me for the work that I do.
This is what I do to bill for one patient. I bring up the patient, click on new, type in the code, a billing item and a diagnosis code. The date is already filled in for me. I create bill and it's done.
It's very simple. Basically, you come in, I see you, I send off a bill. 2 weeks later, there's money in the bank. Patient doesn't have to pay.
I once had to deal with an American insurance company in trying to collect $600 or $700. It took me probably 6 months, probably 6 faxes, 6 phone calls, and then we received a portion of the payment.
We are billing on behalf of the University Health Network for 4 hospitals for diagnostic tests to the Ministry of Health. We don't see any situations where the ministry is second-guessing the doctor's clinical decision on the test. We bill weekly, electronically, and there are approximately 10,000 claims on those weekly billings. And those are handled by approximately 10 people within the department.
This myth about Canadians dying on waiting list is simply that. It's a myth. When people have something really urgent that needs to be dealt with in the Canadian healthcare system, it gets dealt with. The notion that having a single payer somehow causes wait times is not actually borne out by the international evidence on healthcare system design. We see healthcare systems internationally where it's a single payer system and there's virtually no wait time at all. Taiwan being a good example of that. We see systems that have multi-payers where wait times have been a big problem.
There's a lot of mythology out there that somehow there's a big tax burden or a big cost that comes along with the Canadian publicly funded model.
In my 25 years as a cross-border tax consultant, I'd say I've prepared at least 5,000 U.S. returns and about the same amount, 5,000 Canadian returns. The surprising thing is that even though on an income of $50,000, the tax rates in Canada and the U.S. are about the same, in Canada, that tax covers primary health care. In the U.S., there'd be additional cost to that person, either through their own insurance or employer insurance.
Canada now spends half as much per person as we do in the United States, yet their life expectancy has increased faster than ours.
What it's a story of is universal health insurance that very few Canadians would ever imagine reversing. And it's a story of Canadians looking south of the border and noticing we have both spectacular centers of excellence and spectacularly expensive, complicated, and hard to justify distribution of medical care.
I am Dan Conkin, and I'm the president of Amco Manufacturers. We're a family-owned business, and been in business for over 47 years. I'm a member of the Conservative Party of Canada, and we stand for removing waste, being more efficient, and finding ways to grow our own businesses. And one of the greatest ways that we can grow our business is to reduce cost. And that's why we embrace the Canadian healthcare system. What I don't understand is why my fellow Conservatives in the United States tend to fight this.
So my name is Terry Alexander, and I work for Amco Manufacturers, and I've been an employee here for 17 years. From what I've experienced, the Canadian healthcare system is amazing. I've felt very well taken care of. I didn't feel like there was any treatment that was available that they weren't providing for me. My appointments were very quick. While I was going through my treatment of my surgery and the chemotherapy and the radiation therapy, it was absolutely exhausting and very stressful and lots of anxiety. If I had had the added burden of coming up with thousands of dollars for my health care coverage to fight this disease, it would have been devastating. It would have been horrible. When I hear that people say our Canadian system isn't good, it makes me a bit angry because I'm quite proud of our Canadian system.
There is a huge amount of mythology and propaganda that I know is promoted in the United States. All kinds of lies about the supposedly poor quality of our health care and the supposedly huge cost of our healthcare system.
There was concern within the industry that more and more Americans could believe and buy on to the idea, why do we need insurance companies anyway? Why don't we just have a Canadian-style system? Our costs would be lower if you had access to good quality care. So it's very, very important to discredit the Canadian system in particular. Try to find someone willing to tell some sad story.
Under the Canadian single-payer health plan, he was told it would take another 8 months. Then would likely come.
We look for one or two that seem to be compelling that you can use, and to get people to think that that is common. That's the way it is. And there are obviously far, far, far more stories in the U.S. about people who are not being able to get the care that they need than you'll ever find in Canada.
Canadian hospitals and Canadian doctors have more bed days per thousand and more visits per capita than in the United States.
I knew that what I was doing was really at odds with the way the system was really run. And also the fact that Canadians are far happier with their healthcare system than American citizens are with ours. And I regret what I did. There's no doubt I misled people, and it's a shame that I did that because people have an opinion of the Canadian system, partly because of the work that I did, that is just completely wrong. I feel terrible about that. I often say that what I'm doing now is in many ways trying to make amends for misleading people.
We looked at opening up a U.S. operation. We wanted to be closer to our customer base. We wanted to be closer to our supply base. But the more we looked at it, the amount of cost that we would have incurred by having our company relocate into the United States, just through the insurance coverage costs alone, just made it a non-starter. If I have to increase my cost by over $1 million in my company because of insurance coverage costs, that alone would probably drive me to bankruptcy.
In fact, up here in Canada, the major American auto companies, Ford, General Motors, and Chrysler, actually made a public declaration, a public statement, that the publicly funded healthcare system in Canada was an important competitive advantage for their operations in Canada.
What we have now, by comparison with Canada, are the consequences of complexity, of not knowing what you're entitled to, of excessive preoccupation with choice of insurance plan, of facing high deductibles and co-insurance, which the Canadians don't, and of living with a situation which, even if you're insured, the fearfulness of things falling outside the insurance package worry America.
How could you prefer a system where the employer has all the hassle of providing private health insurance, the huge cost of it, and the risk and uncertainty of it?
The other thing that we have to address is the issue of concession bargaining.
Labor negotiations are always a very contentious thing. And we hear about them today, particularly in the public sector, in state government, municipal government, school districts.
very contentious labor negotiations. And almost always, one of those contentious issues is healthcare. If healthcare is no longer part of the bargaining process because it's now covered under a single-payer healthcare system, that issue's off the table.
And if you look at corporate interests, those usually associated with the right side of politics, the conservative side, their interests are enormously tied to reform of healthcare.
As a business owner and also as a former Republican legislator, I've said that conservatives should be supportive of single payer because it costs less.
Talking with corporate executives, a lot of them, I think, get this. They know what waste is. They wouldn't be running successful companies if they tolerated waste in their production system, and they can see the waste on the healthcare side. This crazy transactional system is costing them money without value.
Business, when they look at the single payer model, will come quickly to the conclusion that it is the least expensive, the most supportive of a free market, and will have the most direct effect on their costs of operation.
The cost of my company and its employees goes down with single payer. Instead of high insurance premiums, high deductibles, there's a simple payroll fee, like we pay for Social Security. My company gets out of the healthcare business.
I did a study myself, which estimated 34% waste in American healthcare. The National Academy of Sciences did a study that came between 30 and 40%. The RAND Corporation has a study about 35%, I think it is. $1 out of $3 wasted. 1 out of 3 of $3 trillion is $1 trillion of non-value-added activity in care. It's hard to get that out with a multi-payer system.
In every city, every day, there's people who pay $10,000, $20,000, and $40,000 for the same procedure. The doctor doesn't change their quality based on how much they're being paid. In Massachusetts, the Attorney General issued subpoenas to get this information. And what we found, even for people that are health policy experts and thought they understood this area, the variation in what hospitals are being paid was more dramatic than we thought.
How are the prices set? I'll wager you have no idea, and I don't think anybody does.
This is a situation where nobody really knows what it costs, and nobody really knows what's being billed, because it varies all over the map, and what healthcare systems have learned is that they can charge whatever they want. So pretty soon you've got the MRI that costs $12,000 when in fact it may cost them $300 to provide.
You see, there's no accountability. The buck doesn't stop anywhere. The system is not in control. With a single payer, there's more clout, there's more chance to push back, and to push back on prices, to say no to price increases and forms of pricing that just make no sense.
The reason traditional Medicare has controlled prices better than the rest of the healthcare sector is because they've controlled hospital prices and physician rates. They don't pay just what people want. They pay according to a more reasonable schedule that's more equitable. The only place in the United States where you get drugs at Canadian prices, the Veterans Administration. The VA, using competitive bidding and a formulary list, gets lower prices, and they pay 41% less on average than does the rest of the United States. Are the drug companies losing money selling to the VA? No. They wouldn't do it if they were losing money. It's just they're making a lot more money off the rest of us.
There's actually excellent data showing that when you have an excess number of hospital beds, an excess number of specialists, and particularly excess number of facilities like MRI scanners and operating suites, you get much higher healthcare costs due to much higher rates of intervention, but there's no improvement in population health. So from a population point of view, that money for the excess is wasted.
I don't mean to be critical of the motivation, intent, or goodwill of the providers. They care a lot about what they do. Hospitals believe in what they do. It would be easier if they were bad guys. They're not, they're good guys. But they need somebody on the other side of the table with the authority and the resources to speak up for the people, for the public, and I think that's what a single payer can be.
The reality is every study, including ones done by the Lewin Group, has found savings from single payer. There's not a single study that's ever been done that says single payer will cost more.
Single payer makes economic sense. We save $198 billion by eliminating insurance administrative costs and profits. We save $242 billion by reducing the administrative cost of doctors and hospitals that no longer waste time and staff interacting with multiple insurance companies. We save $116 billion by establishing a fair, standardized fee schedule for hospitals and providers of care. We save $154 billion by negotiating bulk pricing on medical devices and drugs, like all other advanced industrialized countries. The total savings is $710 billion a year. The $710 billion in savings means we can lower the overall cost of healthcare. We can afford $77 billion to cover the uninsured and afford the $129 billion to eliminate out-of-pocket expenses. It's about shifting resources from wasteful spending to actual care.
We're talking about cutting some of the obvious low-hanging fruit, getting rid of some of the most wasteful aspects of healthcare, while still leaving plenty of money for doctors to be well reimbursed, hospitals to be well funded, drug companies will still be making profits. You know, the great irony of all this is when somebody says, oh, can we afford single payer? Is we can't afford the current system. The only thing we can afford is single payer, because single payer is the only way that we can bring costs under control and bring the rate of growth in healthcare costs to a rate sustainable over the long term.
There would be jobs lost in the insurance industry, but a multiple of jobs gained in companies that now can stay in America, don't have to go offshore, can build a new plant, can pay their employees more, putting more money into circulation to support people in other businesses. Overall, it's a job win for America. There's no question in my mind about that.
You're not going to have to worry if you get sick halfway through that effort to create a new business. You're not going to be ruined if your child gets sick. We're going to make sure that that issue's off the table. We unleash immense entrepreneurship. We unleash immense creativity in this country.
Much of the time that is now spent by doctors processing paper for the insurance industry will be turned into time spent with patients.
It really holds out the hope of reclaiming our profession as a caring profession instead of a business. And it says to our colleagues, you're going to be able to take care of your patients according to your best judgment medically. Small private practice would be viable under single payer. And regaining control of medicine as a calling would be viable under single payer. And that's why it's popular with our colleagues.
The national movement for single payer continues to expand, it continues to grow. There are well over 20 states that have solid organizations working on both national and state level single payer. Continues to gain the support of Republicans as well as Democrats, business leaders as well as nonprofit leaders. It brings in educators, nurses, doctors. We've got constituents all the way across the board.
What I would love to see is that policymakers could come to the table, park their ideology at the door, and just say, what we're going to do here is take a look at what makes the most sense for this country, what makes the most sense for our businesses, what makes the most sense for the people who work for those businesses and for others in this country, what makes the most sense in terms of creating a healthcare system that really is the best in the world.
Just imagine what it would mean for this country if we could cut our healthcare bill by 25%. Imagine what it would mean for our infrastructure, for disposable income, for our overall economic vitality. Imagine what it would mean for our business community not to have this albatross around their neck. It would be extraordinary.
We are now going to bring our panelists back up. The next portion of what we're going to be doing today is making sure that we have some time for each of our experts to offer some comments. We're going to start with Dr. Ward. We'll move on to Dr. Beck, and then we will finish up that comment period with Dr. Mantell. We have approximately an hour for this next piece, so each of the providers or the presenters are going to have approximately 20 minutes that they'll be talking to us. Again, you can move about if you need to, take a break, stand up, whatever you need to do. Now again, I'm giving approximate times, and we will come back together and be doing a Q&A right after this. So I'm going to go ahead and turn the microphone over, and we are going to start with Dr. Ward.
So, obviously, I'm an economist, and they just had a bunch of economists talking in there. So a lot of what I have to say will just echo some of what was in there, but I do have some different takes on a few things. You know, the first thing that I want to do, which I don't think came up enough in the video, whenever I give a talk about healthcare, and particularly about the healthcare economics, I always want to try and start by talking about health first. Because it's really easy to get bogged down in financing and insurance and all sorts of stuff. But health is what it's ultimately all about, and it turns out that health is really, really valuable. Right? You know, so I'm an economist, right? So it's not just, you know, it's one thing just to be able to say something like, you know, so my great-grandparents were born at the turn of the last century. Life expectancy at birth in the United States was about 50. Right? So when my son was born 4 years ago, life expectancy in the United States at birth was 80. Right? So we've managed to extend our life expectancy by 30 years, or a little bit more than a century. Right? And so the question of an economist is, you know, we don't just say, look, 30 years, that's great. We actually have to say, how much is that worth? Right? And so, you know, we go through this exercise of trying to figure this out. And essentially the way we do that is, you know, we try and find places where essentially people play let's make a deal. Right? So we're essentially, you know, and so the simple logic goes like this. So imagine that God comes to you in utero and says, you know, pipe door number one is the life expectancy from 1900, 50 years, plus a big suitcase full of cash. And behind door number two is the life expectancy of a kid born today of 80 years, right? So, and the question for the economist is how much money does God need to put in the suitcase to make you indifferent between choosing amongst door number one and door number two? And obviously the response from the, you know, the fetus is, of course, God, I'm a fetus, I don't understand anything you're talking about. But you know, imagine, you know, if we kind of go through that exercise and we try and find places where we, you know, see people moving around and you know, where they make choices about things that put their life at risk and how much you have to pay them to do that. And what we kind of figured out is that, you know, you've got about a couple $1 million in that suitcase to get people to be indifferent between those 30 years. And while a lot of that gain of life expectancy came from public health interventions, most of it from the past 30 years, from the past 40 years, so, you know, since 1970, is actually due to healthcare. Right? We do a better job of caring for people, particularly people with heart disease, but also with cancer. And that drives this gain in life expectancy that we're seeing. So healthcare is this delivery system that gives us longer and better lives, and that what they do is really, really valuable. So how do they do that? All right, so the reality, of course, is how many of you like to go to the doctor? Oh, wait, we have one. No. You know, the standard, you know, most people don't really want to, we want to be healthy. We don't want to consume healthcare, right? So when I teach students, you know, when I'm saying, okay, well, you know, you need to come up with a project idea, I say, well, you know, the first thing you should do is try and imagine the ideal system, right? So what does the ideal healthcare system look like? Let me go to the next slide. I've long argued that it's this, right? So if you have any Indiana Jones fans here, you know, basically the idea is if I get sick or somebody shoots me, what do I want to do? Drink some water, pour some water on it. All better, live forever, right? So yeah, that's kind of the ideal healthcare system. Obviously, we don't have this technology. We have an alternative technology, right? And you know, which kind of combines you with the next slide. We do some research to kind of figure out what can go wrong and how do we do better at it. And then, that gives us a set of things that we know that can go wrong that we then use to diagnose people. And of course, there's, tens of thousands of potential diagnoses. And then we have to match those with the appropriate treatment, which of course, then there's lots of different treatments, right? Which is, I guess we have a bunch of coders here in the audience. And so that's the matching, right? You have this whole list of things. Here's all the diagnosis, here's all the possible treatments. That's how the healthcare sector produces health. It figures out what can go wrong. And then it works to say, okay, well here we figured out what's wrong with you, and we've got the appropriate thing to fix you. Right? So that's what we're trying to do with healthcare. So how does this work? Well, we got to get people, where does this break down? Well, it breaks down if we're not doing the research to figure stuff out, we're not advancing our knowledge. If we can't actually, the next slide, I think this actually is the next slide. Oh, yeah, so what is the impediments, right? So we have ignorance, and sometimes we just don't know what's wrong with people. We're still figuring things out. But also, sometimes we just don't, it's hard to, there's lots of possible things that can go wrong with you. And they all look the same, right? Have you ever Googled your symptoms, right? In fact, I didn't put this in this presentation, but a few years ago when I was giving a presentation, it just so happened on the website Reddit, there was a thread, people who are currently sick, what does WebMD tell you you're dying of, right? And of course, it's like, oh yeah, what do I have? I have like a sore throat and a headache. Well, maybe you have a cold, maybe you have the flu, maybe you have cancer, right? There's always something in there. So it's hard to figure out, what's wrong with people. And then of course, once we actually figure out what's wrong with you, there's a range of treatments and which ones, so that we just have the ignorance, so we have to get over our ignorance. And then of course, even if we know what's wrong with you, even if we know kind of how to fix you, implementing that is hard, right? Particularly for people with chronic conditions. Right? We have to get them to adhere. We have to coordinate a bunch of different providers. Providers are imperfect. They make lots of errors. So it's another impediment to the. But the third one that's ultimately going to spend most of my talk on, is access. Right? We have to actually get you into the system for the system to provide care to you. Right? So next slide. And right now, as we just saw in the video, we have a problem where it costs a lot, particularly in the US. We don't get great outcomes for what we pay. And many have limited access to care, and that all feeds into each other, right? So let's just, I'm going to give you a different version of some of the things that the people just told you about in the video. So next slide. All right, so, and I thought this is a little bit complicated, but what I want to tell you, so this right here, on the horizontal axis is health expenditure per capita. And on the vertical axis is life expectancy. And the lines basically show you from 1970 to 2014. All right, so if you went back to 1970, the US and the rest of the developed world spent about the same and they had about the same outcomes. And over the past 45 years or so, divergence has occurred. We spend a whole lot more, and at least as measured, if you measure quality with life expectancy, we do a lot worse. Right? Next slide. So, but that actually masks a whole bunch of variation just within our country, right? So now if we just look at, this is life expectancy, expected age of death for 40-year-olds, and then this is your household income. And so if you're a rich person in the United States, and red are women, blue are men, life expectancy at 40 is almost 90. Right? So if you're a 40-year-old person with a high household income, you expect to live almost to be 90. If you're at the bottom of the income distribution, and you're a man, the bottom 1%, men, life expectancy isn't even 73. Right, so we have huge variation. So it's 15 years in life expectancy at age 40. This is at 40. You've already lived to be 40, right? 15-year gap between the highest and lowest men, 10-year gap between the highest and lowest women. Next slide. Right, so that you just basically take and you say, look, if you're a rich man, or rich person is a man, rich man in the United States, you live longer than the average in any country by a lot. And in fact, if you're a median man, you're kind of on par with Canada and the US. If you're the 1st percentile, man, you're between Sudan and Pakistan, right? So our issues in the United States with health outcomes tend to be concentrated amongst the low income. Right, so next slide. We also have big variation across the country, right? So as we talk about the US healthcare system, it's worth pointing out that, you know, when we take this graph, and again, I put healthcare spending here and life expectancy at birth here, you know, there's a big range. And in particular, if you live in the West, you spend less and live longer. We're still, you know, none of those states are as good as the rest of the developed countries, but they get a lot closer, right? If you're Utah, where, you know, life expectancy is over 80 and healthcare spending per person is about 6,000, you know, they're not quite to Switzerland, but they're getting, like, you know, closing the gap. Next slide. Now, if we again just go back to those low-income men, you know, you see it again. Here in the West, you know, there's one thing. Life expectancy tends to be, even for the low-income men, tends to be better, and we spend less. So what this tells me, to me, what we see, you know, then here's the South, is that, you know, so it's complicated. Next slide. All right, so what we, you can go skip these, right? We'll just skip over these next two. Let's go to this one. There we go. We spend a lot on healthcare, much more than other countries, even in our low spending states. You know, if you're actually relatively high income, we still spend a lot, but our outcomes aren't that bad. They actually are pretty comparable. But we have terrible outcomes for people with low income. And geography matters, right? So there's something about place that's also mattering here. So what ultimately kind of does this suggest? Well, to me, this suggests that access is a big part of our problem, right? You know, so that was what we just skipped over, and I'll just give you the one highlight from that is, if you look at people in Montana who are uninsured and have incomes less than 200% of poverty, and we're going to use the period before Medicaid expansion, basically 50% of them report that they skip medical care due to cost. Less than half of them have had a checkup in the last 2 years, and less than half of them report having a physician. All right, so, and if you combine all those things, 80% of them have at least one of those problems. So access becomes a big part of our challenge. So next slide. All right, so we're going to deal with access, right? Well, access is about paying for it, right? You know, how do we give care to people, and how do we pay for that care, right? So the fundamental question, if we're going to talk about insurance, right, or just paying for care, it's outside of insurance, is we got to collect money from the people who ultimately receive care, and we've got to distribute that money to producers. Right, so those are our two things that ultimately we have to figure out. You know, we want to provide the care, we want to give access to people, we want, of course, want to do better at all that stuff we talked about earlier, but at a fundamental, from an economic perspective, from a business perspective, we've got to collect money from consumers, distribute it to producers, right? So, well, what are our challenges there? So first, how do we collect money from consumers? Next slide. We've got to collect a whole lot of money from consumers. Right? And this is a highly simplified exercise, right? But it's a useful way of getting it into your head how much money we have to collect, right? So in the United States, average personal health care consumption per person is $8,500 roughly. Life expectancy at birth is 80 years. Multiply 8,500 by 80. You know, your simple lifetime health care consumption is $680,000. All right? That's a large house. So, well, okay, if I've got to collect $680,000 from people over the course of their life, problem number one, some non-trivial but not very large share of people will not earn $680,000 over the course of their life. So it's more complicated by the people who are disabled and thus less likely to work, but also are going to need more than $680,000. You know, we're going to cross there, right? So that's problem number one. So we got to collect this. We got to decide who to collect it from, how to collect it from them, and who pays for what. With, you know, the next problem being next slide. You know, is that, you know, what we spend on healthcare is enormously variable, and enormously unexpected over the course of your life. Now, some people we kind of know, but for most people, so here's the distribution of healthcare expenditures across the income distribution. And basically what this says here is the top 50% of healthcare consumers consume 97.3% of healthcare. So let's flip that around. The bottom 50%, half of the country, consumes less than 3% of our healthcare. The top 1%, or actually the top 5% consume half. So 5% of people, half of all healthcare spending. All right, so healthcare spending is heavily concentrated in a few people. Next slide. Right, and in particular, it's concentrated in people who, tend to have chronic conditions. Right? So if you have 3 or more chronic diseases and a functional limitation, average per spending per year is $21,000. If you're just an average adult, it's $4,800. Right, so I told you it's like $8,500 or $9,000 per person. You can start to see how the distribution is going to spread out. Next slide. Right, in fact, if you have these 3 or more chronic diseases and you're the top 1% of spenders, it's $133,000 a year. So how do we collect, so obviously most of these people can't afford to pay that amount out of pocket every year. So we need some sort of system that collects money collectively and redistributes it amongst people depending on how sick they are, right? And that's what insurance is supposed to do. The idea behind insurance is, if I don't know, I'm gonna, if we start before birth, right? I don't know how healthy I'm gonna be. I don't know what my conditions are. What system would I divide, given that I could end up in this world? Is it one where everybody pays for everything out of pocket? Probably not, because those people would not be able to afford any care, and they would just end up being dead. And I told you health is valuable. So you have to kind of figure out some sort of system which allows us to collect money collectively and then spread it out amongst people who, may not, some of us are gonna end up, I'm gonna put myself in this category optimistically, right? I will be a low health income spender. Why? Because it means I'm not gonna get sick, right? But, you're gonna have to collect a bunch of money for me to pay for this set of people over here, or even these people over here, the top 1% of the adult population. Okay, so we need a system that collects money collectively in a way that allows us to redistribute amongst people across income groups and across health groups. The question is, and this is a fundamental moral question, is how much should you have to pay for yourself? And how much should be through this insurance, deal, right? And that is a question that we have not fully dealt with as a country. And I'm not going to pretend to know the answer to, but that's ultimately what lies at the heart of this debate is, we know that some people are going to spend more, and we know that some people are going to spend less. The question is how much should you have to pay for yourself, given that part of your healthcare spending is your fault, based on your own choices, and part of it is not your fault. It's based on your environment and your genetics. So, those are the challenges that we have to deal with. Skip 2 slides. Okay, so I'm going to set aside the how do we distribute money to providers. I'll come back to that in a second, right? So the challenge, obviously, is that we spend a lot, right? It gets a whole lot easier to collect money and redistribute the money if we spend less, right? But as they pointed out in the film, here in the United States, we spend roughly twice as much as other developed countries. And the scary thing is if you just look at what we spend on, through the government, so Medicare, Medicaid, that kind of stuff, we spend as much just so we're not paying our taxes to pay for Medicare, Medicaid, and what we pay through the government as the other countries do to cover everything, right? So let me say that again because there's some confusion. So, because it's kind of mind-blowing, right? So take all healthcare spending in other developed countries, right? Put that onto a share of GDP. Take what Americans spend for publicly financed health insurance. Those numbers are the same, right? Roughly. So everything that we then pay in the private sector, you know, out of pocket or through private health insurance, is on top. That's the gap, right? Our entire spending in the private sector is missing from these universal systems that cover everybody. So obviously, you know, we don't have, you know, there's lots of different ways that we can try, you know, and develop the payer system. But the real issue, the total number that we're spending is really high. We would like to shrink that, right? You know, and that would give us lots of options in terms of how we do it. So how do we shrink how we spend? Well, spending is a simple formula. It's just the cost of each treatment times the quantity of treatments times the number of patients, right? So if we want to reduce spending, lower prices, reduce the quantity of treatments, or reduce the number of patients, like get fewer people sick. Right, actually, reduce the number of people who are sick. I don't know what happened there. Okay, so next slide. So let's talk about the Q side for a second. You know, so why do we have unnecessary or inefficient care? They said, you know, they said there's this, you know, they said in the video, you know, about a third of healthcare spending doesn't produce health. So, you know, we come back to, we have ignorance, some of that we talked about before, but we also have problems with incentives. All right, so next slide. Let's talk about incentives. And incentives we can talk about on the patient side and on the provider side. On the patient side, you know, patients don't pay the full cost of care. So the idea is that patients then consume too much. Right? You go to the doctor when you don't really need to go to the doctor. You get treated for something when it probably shouldn't get treated for it, right? Next. So just, you know, we know that this matters. You know, so here's just, this graph is from something that they did at the Mayo Clinic when they do with their own employees, introduced cost sharing with specialty care. Here's how much they were using, introduced cost sharing. Oh, and suddenly, you know, people consume less. People respond to incentives, fundamental lesson of economics. The problem with patient incentive mechanisms, so how, you know, this is the idea behind increasing deductibles and out-of-pocket costs, is to get the patients to say, do I really need this care before going and getting it, right? So reduce inefficient care by making me, you know, have skin in the game. The challenge, of course, is that that ignorance piece applies to the patients. I don't know what care I need and don't need. And what we've seen multiple times through multiple different studies is that patients are frequently really bad at deciding which care they need, which care they don't. So if I make them pay more out of pocket, all they do is just cut everything back, right? And so we have to figure out how to, you know, get people to do a better job of being less ignorant so that they say, oh, great, if we're gonna use patient incentives, say, great, I shouldn't go to get that, but I still should go get this, right? So that's you know, we have to combine incentives with reducing ignorance. Next slide. We also have to deal with provider incentives. You know, this is my favorite little example of this is 75% of doctors believe that other doctors order extra tests and procedures because it increases their income. Because in the United States, the dominant way that we pay for care is fee for service. I get paid for doing things, right? Therefore, if I want to make more money, I should do more. And you know, and we have other evidence that suggests that there is a margin along which providers appear to respond to these incentives. And therefore we end up paying for care that maybe doesn't produce a lot of help. Next slide. You know, another form of inefficiency, this one is super annoying. Drug companies make eye drops that are too big and you pay for the waste. Literally, the standard drop that comes out of an eyedropper is 50% larger than your eye can absorb. True fact. Doctor at Johns Hopkins went through the whole process of getting a patent on a dropper that produces the size that your eye can actually absorb. The market has not taken him up on that. You know, another thing is 10% of the top 20 single, so a lot of cancer drugs in the United States at least come in single vials, right? And we basically say, you know, you're this size and you're this size, we're just going to do the same vial. And if you're too small for this, well, what do we do with the extra? Right? So 10% of the top 20 single-use vial cancer drugs are wasted. That's $1.8 billion per year. Next slide. And, you know, ignorance, right? So we have provider ignorance that I told you about earlier, patient ignorance, you know, blah, blah, blah. Let's move ahead to the next part. Skip this one, next one. All right, so prices. Prices are the big part, right? So the big issue, quantity, we have inefficient quantity, but the real reason that healthcare is expensive in the United States is price. Right, so this is the average cost of a normal vaginal delivery. We have been doing this as a species as long as we have been a species. Argentina, it costs $2,200. In the United States, it costs $10,000. You know, I came across a study a few years ago. I lived in Oregon. I was showing in 10 years that price had increased by 60%. Right? Next slide. Here's bite graft surgery, $75,000 versus $15,000. Next one. Nexium, $215 versus $23. Right? So next slide. So prices are the big source of why we spend more. And well, why are prices high? Well, prices are crazy in the United States, right? So the light lines here, these are each line is a region. And then the light lines are what Medicare pays. The red lines are what private insurance pays for a simple knee replacement. You can see 10,000 over 50,000. And as I mentioned in the video, frequently this could be within the same market, right? Frequently it is common for MRIs to cost a range of 300% difference within the same market. Next slide. So why are prices high? Well, part of this is because we adopt technology which is more expensive. Part of this is because we have these administrative costs and we have higher medical education costs. But part of this is we have higher market concentration. We don't push back as buyers. Next slide. Next slide. Yes. Okay. So what's the role for single payer, right? So one is, there's a potential to increase access, right? As if the government insures everybody, well, by definition, we get universal coverage. The second argument for it is it's a way to lower prices. Is if we put everybody into a single buyer, then the hospitals lose leverage relative to the set of insurance companies, and we basically do what Medicare does and say, look, if you want to take it. The consequence, let me skip this one, is, well, how does the system respond if I take all this money out of it by lower price, right? So that can be, maybe you have fewer doctors, maybe we end up with, less supply, and then the other one that comes up, of course, is that we, lose innovation, that there's less money for the pharmaceutical companies and the medical device manufacturers. And the question is why are we the ones paying for it? Why isn't everybody in the world paying for it? And with that, I will stop. And I guess I don't do questions now, we do them later.
We'll do them later.
All right.
Fabulous. Thank you, Dr. Best.
Well, good afternoon, or morning, whatever it is at this point. I'm Carter Beck, and I am currently the Montana AMA representative, and so in addition to being a doc here in town, I spend a fair amount of time. I can just project my voice. Can everyone hear me?
No, you need to use the thing. Yeah.
Hold on. I have to button my shirt too. In addition to being a doc here in town, along with Dr. Mantell, I spend a fair amount of time on public policy and issues related to healthcare reform, both at the state and national level. I started doing this back in 2008 when we were having the last time we had this debate, which was prior to the passage of the Affordable Care Act. And I've sort of stuck with it since because I just find it a compelling problem for all of us. I think it's clear this morning, I think we've made it entirely obvious. We have an affordability crisis in healthcare. And I believe that affordability crisis exists both in the public and private sectors of healthcare delivery. So our government programs, as well as our private programs, are unaffordable. Part of the reason for that is that the two are getting in each other's way. One of the things that the Affordable Care Act did was sort of put a strong arm around the entire healthcare sector, and it began to blur the lines really between private healthcare and public healthcare. And the result of that was the Affordable Care Act has turned out to be anything but affordable. The trajectory of healthcare spending has gone up and not down. And obviously there are very complicated reasons behind that, but it hasn't had the effect that we hoped. It did insure more people. And just to be clear, I opposed the Affordable Care Act back in 2008 pretty ardently, and then I ardently argued for the Medicaid expansion in the state of Montana, because if there was a problem in 2008 that needed to be addressed, it was the Medicaid cliff, and it was poor working Americans who were already having trouble affording health care in the United States. And it turned out by hook or by crook that the big healthcare companies rallied, pharmaceutical companies, the stocks rallied, the big cats in healthcare did well after the Affordable Care Act, and poor working Americans, because of decisions by the Supreme Court, were left struggling. So I've been on both sides of the fence on this, and in the course of it, I've tried to study what has gone on around the world. We've got a lot of other incubators for societal healthcare systems around the world, and I've come to a conclusion that what we need to do really here is both things. And so you say, well, why are you at a single payer conference? Well, I believe that we should collapse all of the government programs into a single universal program, essentially Medicare for all. But I think it's critically important that at the same time we preserve the option to go find your health care privately. If the government's promise of access and promise of delivery turns out to be hollow, which I think there's a very good likelihood that it will some of the time. It'll be great a lot of the time, but when the government says, we're sorry, we don't cover that, you don't qualify for that, you may disagree and you need to have other options. And I'll give you some examples of that. I'm going to try to use very few statistics in this little talk here, because statistics can be very misleading. I can show you statistics to make you believe almost anything I want to make you believe. And the problem is that there are so many generalities built into it that you end up not really knowing what you're comparing to what. Back in 2008, when we had this argument, there were a couple statistics that came out there which I want to put out there. One was the World Health Organization had just done a study that said that the United States ranked 36 in their healthcare system, with Slovenia being right above us and Costa Rica being right below us. And the way they came about that was a very complicated algorithm. There were lots of things built into that. But what I want to ask all of you guys, if you were diagnosed with breast cancer tomorrow, and yes, men get breast cancer too, would you want to get your health care in Slovenia, which was ranked 35th, or in Costa Rica? I wager that you would not. And while we show that the U.S. is lagging on outcomes based on life expectancy, what we don't show is that based on disease-specific survival, we do better than everybody. So you have to be careful about the statistic. Yeah, life expectancy, but what goes into life expectancy? A lot of things. Another statistic that was very important during that debate was infant mortality. And when you really drilled into that, they said, well, we spend all this money on labor and delivery in the United States. Why are our infant mortality rates lower? Why aren't they lower? And when you looked at it, what you found out is that a lot of things were excluded in other countries which were ranked higher that we include. And there was an article in the Telegraph that talked about a lady who had a premature delivery. This is right around 2008. And the baby was born at 25 weeks and 5 days. And they put her in a room with the baby, and she said, where's the doctor? And they told her the doctor's not coming. And she said, what do you mean? She said, the cutoff is 26 weeks. And the baby was small and skinny and pink and well-formed. And over the next 2 or 3 hours, the baby died in her arms with no care whatsoever. That is not counted in the United Kingdom's infant mortality statistics. They say that's a non-viable birth, it's less than 26 weeks. They draw the line. Statistically, at that time, it made sense. If you sat in London and you looked at how babies did when they were born prematurely, that made sense statistically. It certainly didn't make sense for that young woman, who also didn't know that that's what the National Health Service was going to do to her and her baby. And I think that that is the big risk of going to a Canadian-style system, which the video appeared to advocate for, where you have no options. Where when the government has made a statistical determination about what you need, and you and your doctor disagree, we must have a viable outlet. The Canadians have had a viable outlet. They come to the United States. Canada's a country of 35 million people. They're down here all the time. And the companies have developed that market U.S. healthcare services to Canadian citizens, where they say, you need back surgery, you're on a waiting list, we will fly you down, put you up in a hotel, you will have your surgery, and you will go home. And those companies have approached me because, in spite of what they say, there are lines in Canada, and there is limitation of service. And the Canadians have had the good fortune of being able to come here when the government fails them, which is not all the time. Many things about the system are wonderful, but they have had an option. And what I think is really important at this moment is that we try to protect our choice, because ultimately what the government will provide in a single-payer system will not be right for everyone. And that gets to how you make medical decisions. When I see a patient in the office, I decide what is best for that person based on everything I know about that individual. Say it's a 75-year-old man who needs a hip replacement. I don't do hips, but we'll just say that. Do I want to make my decision based on statistics? How does the average 75-year-old man do with a hip replacement? Or do I want to look at everything I know about that patient and everything that I know about my skill and my performance as a surgeon and make that decision? The two are very different. And what happens if we went to a Canadian-style system tomorrow, we would be doing more of the spreadsheet type of healthcare delivery and less of taking care of the individual patient. If we continue around the English-speaking world, I recently visited Australia. And in Australia, they have universal health care. Basically, you can walk into a public facility and get care. And they have private care, which you can purchase under the terms that you decide. And that's where I think I'd like to see us move, where we take care of everybody as best we can within the budgetary constraints of the federal government, but we leave private health care alone and we just let people make their choices. We could group, instead of being employer-based in our health care, we could group by young, active hikers in Missoula, get a group together, purchase health insurance with no penalty. And maybe that health insurance is supplemental. You say it's for those things that the public system doesn't provide. I think that that's where we want to go, and I think that what we can see is in every other sector of life, if you want, you can ride public transportation. If it's not good enough, you can choose public or private transportation. With education, it's very important that we have our choice. If you like the public schools in your area, go to public school. If you don't, go to private school. In housing, we have some provisions for public housing and we have private housing. Even with the Mayo, we have both systems functioning side by side. And I think I'll close with that and say, I think that the worst outcome for us right now, given the trajectory that we're headed, is the Canadian system. I think that while it sounds good, it's simple, and you can make a utopian argument for it, it will turn out to be somewhat hollow. And I don't want any of you to be the woman who has just had a premature baby that finds that baby doesn't qualify for care. Thank you.
So I'm Mark Mantel. I'm a family doc over at the residency program here in Missoula. I'm actually employed by the University of Montana. And I'm actually in the process of training new family docs for the next generation. What Lisa Ray didn't talk about is that I've had an experience through a broad range of experiences and venues of practice in the United States. I'm a former veteran of the Navy during the first Gulf War. So in the military, the practice there is very much like a single payer system. I've also been in private practice, running my own practice, running the bills, managing everything. I've also been in employed practice, and now I'm actually employed by the University of Montana as a teaching spot. So I've kind of experienced the full gamut across the realm. And that gives me a lot of unique experiences and certain areas I'd like to go to. But before I'd like to ask a question to go a different route. How many here have made have made job decisions based upon healthcare, or know of someone who has? They decided, I need to take this job even though it's not what I want because I need to have health insurance. I'm afraid to leave this job because I need to make sure I keep my health insurance. I would like to go and start my own business, but I can't because I can't afford not to be insured. And just show of hands quickly, how many people? Okay. I experienced that same thing. I was in private practice about 12 years ago, and I realized that I was one accident away from being bankrupt as a doc in private practice. I realized my overhead was getting squeezed, the margins were getting smaller. It was costing me more and more out of my pocket to make sure to fight with insurance companies for bills. And I realized that I was also uninsurable. I had a condition called atrial fibrillation or paroxysmal AFib. Happened when I was 24. I've had about 4 or 5 bouts in my lifetime, but it put me in an uninsurable pool. So monthly health insurance for me was close to about $2,000. And that was just for a high deductible program. I had that. Then I also had, if I were to get sick and I no longer was able to support my family, I would have to pay other disability insurance. Those insurances were piling up and made it almost impossible for me to stay in business on my own. And so I made a decision to become employed doc. And it's been a good route to go. But I had to make a decision based upon whether or not I could afford health insurance or not. And I think about, and I'm kind of going a different route, but I think about our Constitution where it originally went. And one of those was promote the general welfare and develop the risk for, or promote the liberty for all of us. And I almost think of health insurance almost as indentured servitude. It prevents us as a population from being able to be free to do what we want to do with our lives. And we almost become an indentured servant to the organization in which we work. And I find that to be a problem. So that's one of the things I want to get, that one of the things we're giving up by not having a universal system or something that pays for healthcare is our ability of freedom. I think we're losing that. One of the things I wanted to talk about, that was one of the things I wanted to get out there and kind of, we don't talk about that much, but we really don't have that experience that other industrialized countries have. Every system is perfectly designed to get the results it gets. And so there's a lot of good meaning people in the healthcare industry that really want to see good results happen. And we have lots of good plans, but every system is designed to get the perfect results we get. So next slide, please. So here are some of the results, and I got this from the CIA World Fact Book. Believe it or not, you can Google CIA, and they have a fact book, and it compares different countries. And we'll go through these. And some of these are the things that Dr. Beck was alluding to. And yes, there are disparities in how the data is collected, but I think it's a good idea to see kind of where we're at. Next slide. So this is U.S. health expenditures. Right now, we're at 17.1% of our gross domestic product. In the next 5 to 10 years, it's expected to go up to 25% if we don't do anything. If you note, that's $3,465,444 billion, which is roughly about $10,725 per person here in the United States. And if you do a healthcare cost comparison, you know, you kind of look at Italy, UK, Japan, Australia, France, Canada, Sweden, Germany. They're all doing programs at about half the cost that we are in the United States. Next slide. Life expectancy, this was in 2017. Monaco, a great place to be, small population, 89.4 years. Israel, 82.5. Sorry? Oh. Canada, 81.9. Puerto Rico, 80.9. And the US, 78.6. And again, these are averages. And I think Dr. Ward showed that there are disparities. These are global, these are universal programs. These are their averages. In the US, for our top 1%, we're right around that 89-year range. And for those that are the lower 1%, it brings it down. And so what we have is this kind of combination between the two, between the wealthy and the poor. What you don't see here is in the past 2 years, life expectancy in the United States has dropped. We have dropped. Part of that, and I'll get to that in a little bit, but I'll go into why I think that's occurring. Next slide. This is maternal mortality, likelihood of a mom dying during childbirth. If you know Greece, they're number one. They have the lowest rate. In the United States, it's down at 47. Just ahead of Lebanon and behind Kazakhstan. The numbers are pretty astounding for us. We have disparities across the country. In good hospitals, yes, you'll get good outcomes. In poor hospitals, you won't get as good outcomes. Next slide. Infant mortality, again, this is what Dr. Beck was saying. Again, some of these numbers are varying based on how the data is collected. But still, the United States, we average about 5.8 deaths per 1,000. Monaco is 1.8, Hong Kong 2.7, Lithuania 3.8, 4.4. Next slide. So the question I have too is why, okay, so we're having these disparities and we pay a lot for our healthcare. Is part of that cost of healthcare because we're big utilizers of healthcare? Or that we have more doctors in other countries? So this is practicing physicians per 1,000 population on the first slide on the left. If you look at other industrialized countries, Norway, Germany, Sweden, Switzerland, Denmark, Austria, they average about one more doctor per 1,000. We're right around where Canada and New Zealand are, about 2.6. The average is about 3.2. And if you look at the number of visits that we use in the US, you note that other industrialized countries have easier access to their doctors. Japan, Germany, Canada, Austria, France. The US, we average about 4 visits per year. Other countries are actually averaging a lot more, and in Japan, they're high utilizers of going to see their doctors. Next slide, please. Hospital beds per 1,000. If you'll take a look at number of acute care hospital beds per 1,000, the average is 2.9. US is about 2.5. Other industrialized countries, they have more hospital beds for the population. Hospital discharges per 1,000 population, you'll note that in the industrialized countries, Germany, Norway, Austria, Denmark, Switzerland, France, have more hospitalizations. In the US, we have fewer hospitalizations at 126. One of the things we have in the hospitals, we have a lot of push to get patients out as quickly as possible, reduce readmission rates. And some of that could be good, that we don't have people bouncing back. But still, it shows that we're not utilizing, or we have as many hospitalizations as other countries. So some of this we're trying to take care of out of pocket. Next. So the bottom line is every system is perfectly designed to get the results it gets. And if we keep doing what we've been doing, we'll keep getting what we've always gotten. An expensive, high-tech, inefficient healthcare system. Next slide. So what I kind of did, and this is kind of my simplistic brain kind of overlooking things, is if you look at the other industrialized countries, there's a common theme. The common theme is they spend about 10% of their GDP on their healthcare. They cover most of their citizens. There's different payment systems. Dr. Beck talked about the one in Australia where there's a combination of private and public. Some are pure single-payer systems. Some have all private insurance, but they're government regulated very, very strictly. But it's about 10% of GDP. The other thing you'll note with these other countries is they have an infrastructure of public health, a strong public health sector. And the other thing you'll see in these countries, and this is probably my promotions, you see that primary care providers make up the bulk of physicians, and the pyramid is a strong primary care foundation with fewer specialties. The U.S. differs in that in several ways. One is we have a private healthcare system. Our physician distribution is tipped upside down. We have a lot of specialties with fewer primary care. And our GDP is at 17.1%. My concern is what we need to do is get to about 10% GDP. That's a goal, I think, of what we're trying to get with anywhere in the country. And that's, I think, what employers want to get to as well. Question is, how do we get there? And so what I want to take a look at, so this slice of the pie doesn't really represent the actual percentages. I just want to show where the money's coming from. So if you take a look, this is my simplified view of who pays for healthcare in this country. Healthcare is paid by one of three means. It's paid either by the government, a Medicaid, Medicare program. It's paid by employee premiums, and also paid by employer premiums. And employee premiums also considering out-of-pocket costs. That's the only place money comes from for supporting the healthcare industry. And I'm looking at that as middle class individual. So I pay FICA tax. That covers government, that covers Medicaid, Medicare. I also pay my own premiums. And I also have my employer paying my premiums as well. So we have a healthcare system that's highly funded by the middle class here in the United States. The poor, they're not really paying right here in the government. They may be maybe getting some help from employer, maybe some premiums maybe, but they're really not involved too much. The super wealthy, because they probably don't have a job, most of their job comes through investments, so those investments are free from FICA, so they're not paying anything into the government. Their tax rates have actually gone down lately. We've seen that. And so they're probably paying some employer premiums because they probably have employees. But really the bulk of the health care in the U.S. is being supported by those that are employed. So what do we buy? Where does that money go? Where does that premiums go? We always think of it going to doctors, nurses, therapists, techs, all the people that are in the front lines of healthcare. What you don't see is who's getting money in the background. In the military, when I was in there, for every soldier we put out in the field, to get one soldier out there, it took about 10 people to support that individual to be able to do their job. So when we think of all the other people that have to support those doctors, we have insurance companies, they take a cut. They're for-profit entities. They're trying to get a return on their investment, a return for their shareholders, but they're the third-party payers. They're the ones control the outflow of money where it goes. They're taking a cut of every dollar that's spent. Pharmaceutical companies, they're taking a cut as well. They're not going broke, they're doing well, so they're taking a cut of your dollar as well. Medical device companies, that could be anywhere from artificial joints to prosthetic valves to MRIs, robotics, all those individuals, those are companies that contribute to the overall cost of your healthcare. Information technology is a new one we added. Information technology was the idea that if you all go to electronic health records, now that we can actually be able to communicate with each other, be able to keep track of things better, get better quality out of the system, that was an added cost that's being taxed out into your dollar that's being spent. Hospitals, they have to stay functioning. They need to have a physical building. They need to be able to pay for the infrastructure of their admin. They need to be able to have, I'm thinking of all the other people. They need to have custodial helpers. They need to have housekeeping. Those are all things that go into the cost of healthcare as well. And then ancillary support. These are your billers, coders. These are everyone else that helps to make the system go. And you'll see there's a lot of people involved in our healthcare system. And it was just recently, the U.S. healthcare sector is the #1 employer in the United States right now. So it's a huge employer. So if we shrink this pie, try to get this down to 10% of GDP, or shrink it by about 1/3, one of the main concerns I have is what's going to happen here with this pie. My concern is I don't see insurance companies giving up their probability of making a profit. I do not see that happening. I don't see pharmaceuticals lobbying to say, hey, we need to take less. I do not see that happening. Medical device companies, still for profit. They're gonna still wanna promote technology, they're still gonna wanna promote their item. This is better than ever. Information technology, they're still trying to make sure we use them, buy their product. Hey, this is gonna make your practice run so much smoother. I've heard the promises before. We can make it run so much smoother, you can see more patients than you've ever seen before. I'm waiting to see that happen. Hospitals, a lot of them, you're seeing one of two things happening now. You see hospitals joining forces, trying to get bigger, so they have bigger group purchasing power. Or you see hospitals going private, so they can actually make more money and keep more money and go out of the nonprofit system so they can stay solvent. And you're gonna see those things happening. Ancillary support, I have concerns. These are people's jobs that we're talking about as we shrink the market or try to shrink that GDP. These are your billers, coders, these are all the other people that support. And I do have worries that if we try to shrink it, it's gonna come at jobs. It's gonna come at people's jobs. And then doctors and nurses and physical therapists and techs, what I kind of see happening, if we don't do this right, we're gonna reach a point where doctors and nurses are gonna be asked to do more with less. And a lot of us in the industry already are feeling that pressure coming down on us. It's a tough situation we're in. I really believe that right now, we're on the cusp of a bubble bursting in the US. I'm looking at some, I would call it the canary in the coal mine, kind of watching the things that are happening and seeing things that are taking place. The fact that we've lost life expectancy over the past 2 years, a couple things have happened with that. Most of that's due to the opioid crisis. And the reason why, because people are dying in their 40s and 50s from opioid overdose. But that's a sign of a poor healthcare system. We've cut the fringes of mental health. If you kind of look at it, we've cut that benefit out of healthcare because we don't think it's necessary. And we think people need to purchase extra programs, purchase extra policies. So you're seeing those things erode on the boundary, so you're seeing life expectancy drop. You're also gonna see as rural places, rural hospitals in the US, they're closing right now. In the past, since 2010, there's been about 80 rural hospital closures. Most of those occurred in states that didn't do Medicaid expansion, so most of them were concentrated in the Southeast. It's anticipated that over 700 rural hospitals are at risk of closing in the next 10 years. So what you're gonna see is our rural network kind of dissipate, go away, and you're gonna see these larger healthcare disparities where rural people in America have less access to healthcare than those in cities. I really think that we're at a cusp. And that we really need to move in the right direction, but we need to do it in a way that we get all the partners up here talking about which direction is best for the U.S. So I'll close with that. Thank you.
Okay, so for this next part of what we're going to do, we are going to have questions addressed by our panel, and we're getting a lot of questions coming in that I was able to read as we were discussing. So as the panelists, when you're getting ready to answer a question, if you could please speak into the microphone, and we're going to be passing a mic. Okay, so thank you to all of you as panelists. We appreciate your input, and we appreciate all of your knowledge and your time being here today. We do have a hard stop in the room at 1 o'clock. So we do want to get to as many questions as we possibly can. A couple of questions have come up, and I'm going to start with the question that Dr. Mantell basically ended on, was the idea about jobs in the United States and how healthcare has created a lot of economic drivers within the employment piece, far beyond just the healthcare providers who are doing the care. As we change whatever system we come to, as the system does change, how do you see those jobs shifting? Where do you see them possibly going? Do you have any ideas about that?
I have no idea. Actually, I do. Thinking about it. As we reduce, and most of these jobs, if we were to reduce or go down to a single payer system, we're looking at job loss mostly from, as some of the coders have seen, You probably will still need some to do that in the back office, but you won't need as many fighting with insurance companies. We have a public health system that needs to be buoyed up. So there's actually a possibility for, I'm thinking, job growth there, especially with aging population of our baby boomers. That would be a great place for a job explosion. Take some of those jobs, move in that direction. Again, it needs to be done well thought out. There, hopefully, as the cost of business decreases in the U.S., because employers have to pay a lot for the cost of making their product here in the U.S., that may increase more jobs in that venue as well. I might actually ask our economist if he has some thoughts on that as well, where these jobs might go, because really, you know, I kind of jokingly always say we have a medical industrial complex here in the United States. And it's gotten so big that actually is driving everything that we do in the U.S. It needs to shrink a little bit, but I like to ask our economists as we shift. It may be painful, but I don't think we can keep going in the same road we're going.
Yeah, I mean, that's why the biggest barrier to any kind of change is the fact that 17%, actually almost 18% of the economy now is tied to healthcare. So that 18%, if you come at it and say, we'd like to take a bunch of your money and do something else with it, which is what the rest of us want to do, although I guess there's a bunch of people who are in that system, so maybe you don't want to do it, but, so the people that are outside the system, you know, all of the money that flows into healthcare comes out of your pocket, right? Every single dollar, right? There's no magical somebody else is paying for it. You're paying for it through taxes, you're paying through out of pocket, you're paying through premiums. So the payer would love to get some of that money back in their pocket. But to do that, they're fighting over the same dollar, right? And so the question is who has the clout to take the dollar? So if we assume that through some magical force of politics, that the consumer manages to collect some of that money back, or perhaps more accurately, reduce the growth of it into the future, right? So that 15, 20 years from now, they have more money in their pocket than they would have otherwise had. Where does it come from? That's a good question. It depends on what the system that you design looks like, right? If you design a system that, you know, reduces on a bunch of admin and overhead, well then you'll lose admin and overhead jobs. If you try and reduce, if you try and economize on price, so we lower the price of pharmaceuticals, we lower the price of medical devices, we lower what we pay physicians, well then you might lose jobs in the research in pharmaceutical or the marketing of pharmaceuticals. You might lose physicians. It really depends on, you know, the system will respond to the incentives that we create for it. And until we know what that alternative system is, I can't tell you where the jobs are coming from. But I can tell you that any attempt to actually reduce money in healthcare will come with a huge fight.
I'm going to try and, again, be critical of statistics here. So, you know, it's said that the U.S. spends more per capita on healthcare and as a percentage of GDP and so forth. I think if you look at other spheres of life and the U.S. versus the rest of the world, you come up with similar statistics. It has to do with the way those numbers are constructed, and we put a high value on healthcare for sure. The healthcare explosion started in the 1940s when penicillin first became commercially available. That was the beginning of healthcare as we know it. At that time, we spent 0.5% on healthcare. Was that the right number? When we were in the 70s and we were at 7-8%, was that the right number? How do we know what the right number is? Because if I say to you, I have penicillin, and I'm going to cure you of an otherwise fatal bacterial infection, all of a sudden you're willing to spend some money, and we go from 0.5% to 1% of GDP. If I say to you, in the 1970s, I have a cardiac bypass procedure which will take care of your chest pain and your shortness of breath, we now go from 6% to 7% or 8% of GDP. So what is the right number? If I say to you, I can make it so you live healthy without Alzheimer's disease to 200 years old, we could be at 25% of GDP. All these things come with a cost, and so I don't believe that we know what the right number is. And what I do think is that it's critically important that we're all able to make our choices on how we want to distribute our resources. Do I think our current system is wasteful? Do I think that there's corruption in the system? Yes, of course I do, but I think we should be very careful of saying because Australia is at 8% or 9% or 10% or 11%, that that's the right number, because I don't think we know what it is.
Thank you. Thanks to all of you. The next question that we're going to address, and this is for everyone, please. Do we know when and why insurance became tied to employment? Do we know how that system started?
Yes.
Do you notice how they're all shaking their heads? Absolutely, so please.
During World War II, we had price controls in various things. And so how did employers figure out to try and raise wages when they couldn't raise wages? Well, they said, here, let's give you insurance. And at the same time, they lobbied Congress to say, if we give people insurance, they don't have to pay taxes on the value of the insurance. And so we created this employer-based welfare system, which was very nice to lots of people, and we've managed to keep it in spite of the fact that it's extremely stupid.
So we're going with a...
What he said.
Edited on that.
Okay, so I like how they just do the ditto as we go down along there. Thank you. Our next question is this. How could a single payer system benefit from integration and value-based purchasing in order to make it more cost-effective? How does a single payer system integrate for purchasing? Now, I think that this question really predicates or would assume that other players in the market aren't participating. So drugs are not going down at the same rate of cost, nor are pharmaceutical companies willing to take a lesser share.
I'll take a shot at that. So right now, CMS, who is the biggest healthcare bureaucracy in the world, is the Centers for Medicaid and Medicare Services, has launched a sort of a value-based plan. It's called various things, but it's merit-based incentive program. There's various things where they're trying to tie quality to reimbursements for physicians. And it turns out that it is a very, very complicated thing. It's very difficult because one of the problems is who defines what quality is. You know, I would like the patient to define what quality is. What Washington decides is quality sometimes is corrupted with other influences and isn't necessarily what we all think. So almost certainly what is going to happen, whether it's what should happen or not, is it will be some version of the various performance models that CMS has put out over the last 10 years.
Yeah, I mean, we're trying lots of things. The question is can we figure out something that's somehow better than, so fee-for-service has its problems, quality-based payment has different problems. And the question is can we, through trying out different stuff, land on something that somehow works better? It will not be perfect. That is it won't be perfect. But what we have isn't perfect either. So the question is it better or worse than what we have? And that's only experimentation and willingness to learn will get us there.
I think one of the things, and maybe I'm trying to go this way, what made me think of a single payer system, what it does offer is group purchasing power. If you look at hospitals joining other hospitals, large organizations, as you get bigger, you at least have the possibility of negotiating prices and setting price, a little bit of price control. And a single payer system has that ability to do that. Again, I go back to my military time, and I always think of, always remember when you're in that jet flying, that was built by the lowest bidder. So it goes a little bit to what Dr. Beck was saying, is that, you know, yes, a single payer system will give group purchasing power. What are they gonna purchase and what are they gonna purchase for you? And are they gonna make the right decisions for healthcare? So it's a slippery slope, but that's one advantage of a single payer system.
So that's a theoretical advantage. And so what everybody in this room should know is that the largest expansion of government-provided health care in recent history occurred under a Republican administration when Medicare Part D was launched. That was, it's been a very expensive expansion of healthcare in the United States. And, you know, and ironically, it's a Republican administration expanding these social programs. And one of the things that happened at that time is that the pharmaceutical companies had a fit. And the pharmaceutical companies negotiated with Washington to the point where Washington said in Medicare Part D that we will not negotiate on price with Big Pharma. That we will take the sticker price for everything. And the ramifications of that are unbelievable, but it turns out it's very expensive drugs. And then in the Obama administration, in the Affordable Care Act, renewed the sunset. They put a 5-year sunset on it. And the Affordable Care Act renewed the provision that the largest purchaser of pharmaceuticals in the world, doesn't negotiate on price. So what Mark says makes sense, and that's the way it should be. It hasn't turned out to always be that way.
That was one of the, I wanted to use that in my talk, but in theory, single payer gives you the monopsony power, the single buyer, which you can use to lower prices. But that's a choice that politicians have to then make to enforce, you know, use that power, use that leverage. And as we saw with Medicaid or Medicare Part D, they chose not to. And so we already have an example in the United States of us not choosing to use the power that we have already to negotiate lower prices. And that's what goes back to what my previous answer, which is you have a big fight. Whenever this comes down to a Washington-based thing between this giant portion of the economy going and saying, yeah, no, we don't want to lower our prices, so don't do that. And then it somehow doesn't happen.
I was just gonna dovetail on that, and I always think of something my dad always said, is that, you know, power equals money. And right now, when you look at who controls the purse strings right now, it's the government and insurance companies are controlling where the premiums go and how they go. And so it's been taken away from the people that are trying to do the work.
Excellent, thank you. So we're going to stay along that same vein. It seems like a lot of the different questions that are coming in are about purchasing, pricing, and pricing structures. So another question has come up, and this question really asks to all of you once again. What about health costs, which are not really considered to be quote-unquote medical, if you will? So being part of long-term care, being part of hospice, even though there are obvious health costs in there, residential care, mental health, which was mentioned. What about some of those costs that fall on the outside of the direct care that's being delivered and maybe the living circumstance for that care that's being given? Okay. You notice how they all jumped right on that.
Some of the massive inefficiency in our system comes from the fact that we don't spend enough in these other areas, right? So my dad builds healthcare buildings, and so he talks with lots of healthcare providers. And you know, so he's over in Oregon, where they moved in with Medicaid expansion to these coordinated care organizations, right? And one of the big advantages that one of the coordinated clients came to him and said was, it used to be, whenever it got hot, old people would end up in the emergency room. And now the coordinated care organization managed to negotiate through the loopholes to say, we'll just go buy these people air conditioners that keep showing up, right? You know, and you know, it's whatever, they'll go buy a $200 air conditioner and they're gonna save, you know, and you know, they documented the savings of this kind of stuff. So there certainly is advantages from us figuring out how to do, you know, better home-based care, make sure modifications to people's homes so that they don't fall or they don't get hurt. You know, there's lots of places where we have created a medical system but not a health system. And so there's, I think there's lots of opportunities. Some of this, my academic research is in this area in terms of trying to figure out how to do better for people's health through spending in other ways. And the question then becomes, well, where does the money come to do that? And how do you, extract it from these other places where you think it's going to go otherwise, because they don't necessarily always want to give it up.
This touches on one of the things that is sort of pregnant throughout this conversation, and that is, where is the limit of the healthcare system when we define what percent of GDP that we are spending? What spheres of life is the healthcare system not involved in? When we track mortality and gang violence or in the inner cities is causing an effect on our mortality, is that a healthcare problem or is that a societal problem? Should we be rating our healthcare system based on statistics that are coming from violence and accidental death or not? With the long-term care situation, we're at the fringes here, because if grandpa has Alzheimer's disease and he needs help, basically his children have a problem. And they say, I'm busy, I have a job, and I can't take care of them, and put them in a home, and then say it's all of our problem to take care of grandpa. When the old days, what you do is you bring them home and you sucked it up. And then we say, at the same time, we're saying it's everybody else's problem to take care of grandpa, but at the same time, we're saying we spend too much money on all this stuff. So which is it? Are we expanding to better mental health and better long-term care, expanding the system and spending more money, or are we going to take some responsibility ourselves and take care of grandpa? That's a decision we have to make as a society.
I'm going to go down the same vein a little bit, and one of the things I'm thinking about is I have a good friend who's a wildlife biologist professor at the University of Montana. He works at, I don't know if this is kind of going circuitous, but it'll actually make sense. But his focus that he's working on is the sage grouse, trying to save the sage grouse. And, we kind of had this conversation. He's trying to save the sage grouse not by saving each individual sage grouse at a time, but by saving the environment in which they live. And kind of the way our medical system is set up is we're trying to save the individual one at a time without paying any attention to the environment. And I kind of compared it to, he found a sage grouse on a highway that got hit. He would take it, our system, the way we do it, would take that sage grouse in, fix them all up, and then throw them back on the highway again. That's kind of the way we do medical care here. We're not doing anything to actually help support them, and that's where other countries, I think, actually do better with some of their healthcare outcomes, is they have, and I don't think this actually goes into when they call their GDP and how much they're spending on healthcare, is actually going to a public health system. And so they probably might be spending similar to what we're doing, but they're part of that, what they're counting, because GDP toward healthcare is direct care, not actually going to the public health system that we really need to focus on. So
I'll clarify the statistics on that. So public health expenditures are included in healthcare. What's different, what they do differently, which has been shown to be related to health, is the social safety net.
Yeah.
So they spend more on a variety of other social programs, and somehow those then are what correlate into a direct public health spending typically is included in the healthcare spending accounts.
Okay, so we have another question that comes, and it's just a tiny bit of a different thing, it's a definition. So we're hearing two different terms or terminologies, and those are universal coverage versus a one-payer system. So can you briefly explain what those differences are, and how does one work better than the other if there is an advantage?
Okay, so universal just means everybody has health insurance. Single payer means that everybody is covered by a single provider of that insurance, right? So the Affordable Care Act was designed to try and get us close to universal coverage without moving us to a single payer. So does one work better or worse? It's really just a big bunch of trade-offs. And I actually really recommend, so last fall, the New York Times Upshot, they did a little game you could play where you could go and you could, basically there's a little tournament of, here's 8 different healthcare systems and the trade-offs associated with them. Which one would you prefer to live in? right? And they had experts debating it, as well, kind of along the same times, and, because the experts ultimately end up in different spots as well. But, what are the trade-offs associated with them? Well, it's fundamentally, okay, so Canada is just a pure single-payer system, right? One insurance provider for everybody, but you lose the extra choice. France, Australia, a variety of other countries have a mixed system. They have a universal catastrophic or basic system, plus private supplemental insurance. The UK is fully socialized, right? There's not a single payer, it's literally just government-provided healthcare. And so you have these variety of mixes, and they come with different trade-offs in terms of who's paying for what, who's deciding what's included in different stuff, and how much flexibility and choice do you have outside. When I did the Upshot thing, I'm pretty sure I ended up in France, which is universal catastrophic with employer-provided supplemental insurance for a bunch of other stuff. But other people, obviously, because you can see the statistics end up in different places. The one thing that you almost never saw was people ending up in the United States.
So it should be pointed out here at this point that Canada has been truly single payer, and that meant in Canada that Canada calls their universal health care system Medicare also, it's Canadian Medicare, that it was illegal in Canada to publicly finance or to privately finance and deliver care. The health system said you may not set up a clinic and take cash. And what has happened over the last 10 years or so, because of very long wait lists and because of coverage decisions and determinations, is that in defiance of the Canadian federal government, in defiance of Ottawa, free-standing independent healthcare clinics have popped up particularly in British Columbia. So while we saw everybody in Vancouver saying about how wonderful it is, what's happening is people are openly breaking the law to get people what they want. And so now you have multiple payers now in Canada, and the same is true in the United Kingdom. There is a private system in the United Kingdom, but there is universal coverage, which means if you live in the UK, and we get into issues with illegal aliens when we start talking about this, but if you live in the UK, you can go to the public clinic, period, that's it. And the same with Australia.
Actually, that leads into our next question. So the next question really came up, and it's come up on several of the cards. When we're talking about coverage for everyone, the terminology everyone, does that mean all residents? Does that mean those people who are residing in a country or an area legally? Does that define what happens with the shift in population and movement? So what does that really mean, and do we have any idea how that will really be true coverage for everyone?
So I'll just answer that. That's a difficult question. Here again, we get to the edges of what is healthcare policy and what is immigration policy. And if we have a broken immigration policy, which I think all of us, regardless of what you think about the situation, agree current situation is broken, what do? I wrote a resolution for the American Medical Association basically advocating for single-payer universal health care with a private system side by side. And what I said is that if you're in the United States, as a citizen or a legal resident, that you're covered. What happens then to the illegal aliens? Well, they end up going to the emergency room like they do now and getting care, and we all pay for it a different way. So maybe it should be the other way, and you just have to make a decision as to where you want to define healthcare, where you want to deal with immigration.
Yeah, I think that's pretty, these are definitional things, and once you reach the fringe of any kind of definitional system, you end up in places where you're like, I don't know what to do. That's not an easy choice. But yeah, usually, as long as we're dealing with, okay, we know what your citizens are, we know what your permanent residents are, we know what your kind of, people who are here legally are, great. And then what you do with people who are here illegally, they're already here illegally. Like, what can you, it's already, you're already into this, like, well, they're here, okay, we can try, and
it depends on the kind of system you have in terms of what's publicly available and who's checking what, right? If you just are basically creating a public clinic where you're there, like, great, you know, we're just gonna treat you. So I don't know, I don't have a great answer though.
You know, I don't have a great answer on this one either. It comes down to your philosophy on healthcare a little bit. Is healthcare a privilege or is it a right? And that's still a debate that we really haven't finished answering that question in the U.S. You know, there are those that think it's a privilege, and there are those who think it's a right. I know within the medical system that if an illegal alien shows up and they need health care, that will be provided for them. I don't think any of us would be doing our patients well or doing our institution well by turning patients away. It just gives a bad image. So that's a debate that we still need to figure out.
Thank you. Now we're going to shift gears again, and we're going to move to something just a little bit different that's come up in many of the cards. So, and I'm going to ask you, Dr. Mantell, to take this one first, because you're currently working in a residency program, and you are currently getting people ready for that next generation to take care of the next group of people coming up. So the question really has come up. How exactly do you see the changes in medical education changing, if there is going to be a change, going to a one-payer system or universal health care? Will it shift the curricula or anything that you're currently doing?
I don't think it's going to shift curriculum. You know, our residency program is dedicated to preparing providers for the rural environment. Yeah, and so getting them trained is the main goal. We don't do a very good job training them on the healthcare system and how to navigate it, how payers work, how those items work. But I would say the majority of the docs that are graduating are going into a healthcare system or an organization that actually has all that infrastructure already built for them. I don't see many primary care docs going into independent practice because of the amount of bureaucracy and red tape and the amount of number of people that you have to employ to make sure you stay yourself solvent. I think mostly we're preparing them for employee practices down the road.
Thank you. And I'm going to come to Dr. Beck next with another question. And this one really relates to several questions that have come in about IT technologies and the electronic medical record. And as a private practitioner or a practitioner who is working in a large hospital system that has one electronic health record, has that helped you? Has it hindered you? Does it take more time, less time? We're not saying what the health record is. We're just
You know, don't tell anyone, but I like the thing. I find it very efficient, and most people hate it, and it does have its frustrations. And I was not looking forward to adopting it. It does take some time, and it does sort of constrain the way I practice somewhat. It sort of provides a framework that I have to hop through, and a lot of that's driven by Washington's mandates and the pay for performance sort of thing. And a lot of it isn't clinically meaningful. So, for example, the VA, who's on a different record, but the VA figured out if they use the word discrepancy in their in one of their history and physicals, that they got paid by the government 2% more. So guess what? Every patient had a discrepancy, you know. And so I like the thing. The more cumbersome the sort of the hoops I have to jump through, the more check boxes I have, the worse it gets, and it does end up taking time away from patients.
I'll just dovetail on that. The EHR record has a great capacity use, really good. The one downside is that none of the EHRs talk to each other, so we're losing a great benefit for efficiency that could be there. And so it's not uncommon if someone's not in the same system, I still have to get records faxed to me. I have no access to any of the past medical history. So that creates barriers for getting efficient means of information transfer. Some of those things need to be worked out.
Excellent. Now we've got one last question, and this is going to have to be our last question because then we're going to wrap up. But this is a question for everyone, and I'm going to start with you, Dr. Ward. And this question really came up about showing a slide earlier in your presentation you had different population zones in different parts of the United States, specifically Utah was mentioned. And in that, you mentioned that people in Utah had maybe a longer health span and possibly lower cost for their healthcare coverage. Can you expand on that just a little bit, please?
Mormons are really healthy. They don't engage in a bunch of, drinking and smoking, and I think that's really, so outside of the cultural stuff that goes along with the Mormon stuff, the larger Western thing is interesting, right? Because not Utah is the furthest one, but California, Idaho, Oregon, Washington, Montana's got the fringe of this. I don't know exactly what it is. I assume it's related to outdoor recreation, lifestyle choices, because the alternative, the antithesis is all in the Southeast, where health outcomes are a disaster, and every health indicator is a disaster, whereas our health indicators are all generally pretty good. So there's something cultural, and believe it or not, I do actually have a research project in the works on at least people with disabilities across these places. So hopefully I'll know more at some point.
There's no doubt that health habits are very important, and that different regions of the country have different levels of obesity, levels of smoking, levels of drinking, and various self-destructive behaviors, which I think every doctor in America would recognize as a huge driver of American healthcare expenses is that we do not have very healthy lifestyles as a country. Another thing that goes into the cost of at least private health insurance in the United States are the insurance mandates, which are regulated at the state level. And one of the things is if you look at state by state, the average cost of a health insurance policy varies dramatically based on the state, basically what the state legislature has done. Massachusetts, the last time I looked at this was quite a while ago, but Massachusetts was far and away the most expensive market in the world. And it's not necessarily because of the health habits of citizens in Massachusetts, is because what the legislature had done, whereas Kentucky was maybe a policy that was $5,000 a month in Massachusetts was $1,000 a month in Kentucky, and it's based on what the legislature did. When the Montana state legislature enacted an autism mandate, which said that all insurance sold in Montana had to cover autism, it cost 2%. And so while the autism advocacy group was very happy that they got included as a mandate, the rest of us paid 2%, whether we felt that was an important feature of healthcare insurance or not.
The big part for difference in cost is health disparities, access to care, and health behaviors. In the Southeast, they have some poor health habits. From living down there for a while, you see that. Higher rates of obesity, higher rates of diabetes, and all those things go into the cost of healthcare and their longevity. In primary care, if it wasn't for people smoking, people drinking, not exercising, I would be out of a job. So or eating healthy. So it's healthcare choices that they make and regional differences on that.
Excellent, thank you. Thank you very much to each of our panelists for coming, and we really appreciate your input, your different viewpoints, and the ability to talk about a very difficult topic and do it in a way that allows us all to learn something. Thank you to each of you for coming and being part of our audience and giving us some questions. I know that we weren't able to hit all of the questions that were presented. I tried to put a lot of the different groups of questions together as we were asking. By a raise of hands, after being here today, how many of you have something that you're going to think about maybe a tiny bit differently? Or maybe you have a new idea about a one-payer system. Did anyone learn or think of anything new? Excellent. How about any of you by raise of hand are getting ready to go out there and make our healthcare statistics change because we're going to go and have lunch and eat something greasy? Well, I'd like to say thank you, and Yes, we do, and thank you all for coming. So I'm turning it back over to Deb.
Of course, I need to bring the mic on the very last thing, because that's how I roll.
Just go ahead.
I'm here representing both the AAPC and the League of Women Voters. Wearing my AAPC hat, I encourage AAPC members to become more involved in addressing the problems in the medical care system in this country. We live with them every day. We can become more active in our association to inform ourselves and then take action as individual citizens. Wearing my League hat, I want to share with you the position of the League on healthcare. The League does not support candidates for office, nor does the League support political parties. We are, however, active in advocating solutions on specific issues. In addition to defending the principles of democracy by supporting voters and providing information on issues, the League also has a grassroots consensus process that it uses to take stands on issues of concern to its members. Here is the portion of the League's position on health care that is relevant to today's presentation. The League of Women Voters of the United States believes that a basic level of quality health care at an affordable cost should be available to all U.S. residents. Other U.S. healthcare policy goals should include the equitable distribution of services, efficient and economical delivery of care, advancement of medical research and technology, and a reasonable total expenditure level for healthcare. The League of Women Voters' healthcare position includes support for strong mechanisms to contain rising healthcare costs. The position calls for a national health insurance plan financed through general taxes, commonly known as the single-payer approach. A majority of Americans say it is the federal government's responsibility to make sure all Americans have health care coverage, and a growing share now supports a single-payer approach to health insurance, according to a new national survey by Pew Research Center. Currently, 60% say the federal government is responsible for ensuring health care coverage for all Americans, while 39% say this is not the government's responsibility. These views are unchanged from January 2017, but the share saying health coverage is a government responsibility remains at its highest level in nearly a decade. So, wearing my League of Women Voters hat, I encourage you to become involved in our democracy, learn more about who is behind the failure of our elected officials to solve the pressing issues of today. Join the premier organization that has been defending democracy for nearly 100 years as we strive to inform ourselves on issues and fight to protect the process of our democracy from those who would make of it a sham. Coming together to learn more and discuss the issues we face is a fundamental exercise of democracy. Your presence here today shows that voters do care, that we are committed to civil discourse in pursuing solutions to financing and administration of health care in our country. A final round of applause for our panelists and our moderators. I want to thank the panel members for taking the time to share your insights and observations about healthcare insurance. Thank you to Lisa Ray, your tremendous support and excellent moderating skills. Commitment is what transforms the promise into reality. It is the words that we speak boldly of your intentions, and the actions which speak louder than words. It is making the time when there is none, coming through time after time after time, year after year after year. Commitment is the stuff character is made of, the power to change the face of things. It is the daily triumph of integrity over skepticism. Thank you very much.